So today is a special day. It's probably on most people's radar. We're not in the path of totality, but 98% for the eclipse today. And so we are going to pause this afternoon a little bit before 2, where everyone will have eyewear. Please wear the glasses. They look silly, but it's for your protection. You're not supposed to look directly at the sun during the eclipse. And we won't be in totality, so I don't think it will ever be safe to take the glasses off. So just put them over your eyeglasses if you have eyeglasses. We'll all look silly together, and it will be really fun. You'll see all of campus will be outside. It will be a really wonderful community event that people are traveling from all over to experience together. So we're excited. I will just thank Dr. Larissa for putting this a little more on our radar. And then for Dr. Susan for noting that her panel is being eclipsed. So that's the special note for today. Restrooms, women's restrooms are right out the door and to the left. Men's and women's are downstairs all the way at the end of the hall and to the left. And I'm gonna just turn it over to Dr. Neal to give you a brief, to introduce himself and welcome you, and then we'll get started with our morning program.
Thank you, Laura. Good morning, everyone. So for those of you who have attended iChad events before, you might have been expecting the man from Kogelo. Unfortunately, he's not here right now, but he will join us. So you have me instead. My name is Neal Tutlam. I'm an assistant professor here and one of the associate co-directors for iChad. Really delighted to be here and welcome to St. Louis. For those of you who are coming to the US for the first time, welcome to the US. We have a beautiful campus here. If you haven't had a chance to explore yet, please explore. We have a lot of free things. Forest Park, one of the largest parks in the country, is right across the street from us. There is a zoo, there are museums. Please explore while you're here as you learn as well. Thank you very much. Okay. And now I'd like to take this opportunity to welcome iChad leadership. Dr. Fred Saumala, our co-director and founder, and Dr. Ozge Sensobar, who's one of our co-directors, and Dr. Proscovia Nabunya, who is also one of the co-directors, to come and welcome you.
Oh. Okay. Good morning, everyone. Good morning. I know that some of you are jet lagged, so I'm trying to shout, okay? And that's impolite I would use the Ugandan culture. I won't say, different tribes, but the Ugandan culture, people are always polite. So when you shout, then there's a problem. But here, there's no problem. Good morning, good morning, good morning. And, and welcome to Washington University. I'm extremely excited. Our plans were being kind of disrupted because of flight delays, flight cancellations, but at the end of the day, for those ones who believe in God, God made it. For those ones who believe in Allah, Allah made it. For those ones who believe in heavens and earth made it, okay? We are here. So we want to welcome our Honorable Minister of Health from Uganda, Dr. Cheng. Thank you so much, very much for coming. Thank you. Thank you so much for honoring our invitation and for coming. We are extremely honored that you could fly over 30 hours to come to rural Missouri, St. Louis, and really honor us. And don't take it bad, George William, but I'll tell you that poor George, when we told him he was coming to Washington University, they bought a ticket going to Washington. And then all of a sudden we said, George, Washington University is in Missouri. He said, oh, sorry about that. Then, so anyway, so we got publicity out of this provost. So now they know where Washington University is. Okay. So we also want to welcome our provost, Beverly, my boss here, the provost for the university. You are welcome. Thanks for always being there for us. Thank you so much. I want to welcome the dean who hired me. I always still call her Dean Mary McKay. She's someone I've known for over 20 years now. and she has traveled to Uganda with me multiple times. So she knows Luganda, she knows some Acholi, anyway, she knows some Swahili. So she's very good. So Dean Mary, thank you so much really for always being there. I also want to welcome my boss, immediate boss, Dean Dorian Traub, who is the Dean for Brown School. Thank you so much. I mean, really, we are very, very honored to have all the big shots who make the policies and move the agenda in the university here with us, okay? So you can, in Uganda, they say kuyoya. I don't know how they call it in English, but you can crave for anything and it will be given. So thank you. But I really also want to thank those ones who put this program together. So at CHILD, we always believe it's a family. And that's why, although I'm the founding director, but I'm just one of the 3 directors who run CHILD. And we always believe that it shouldn't be a one-man show. It shouldn't be one person, but we work as a team. So first of all, I want to thank Laura, our associate director for training, who put this together. Bethel, who is out right there. I don't think there's anyone who doesn't know Bethel, really, really, really. I mean, you know, normally when a flight is canceled, you deal with the airline. But when the flights were canceled, they were dealing with Rachel, with Bethel. So really, it's, you know, so Bethel, thank you so much. I want also to recognize Chelsea, who is our program manager for the trainings. Chelsea, thank you so much. I want to recognize 2 other co-director, associate directors. One of them is, you know, Dr. Tatram. Thank you so much. One of your MCs, okay? And then I want to recognize long lost friends, you know, Dr. Pauline, I call her Pamela sometimes, Dr. Pauline, whom I've not seen in a long time. We've been communicating over time. Really, thank you so much for coming. These are very, very big people in Uganda. Some of the trainees who are here will tell you that, you know, she chairs the Department of Medicine at, you know, the medical school at Makerere. So in most cases, it's hard to get into our office because that schedule is very busy, I'm sure. Then, of course, my colleague, my friend, the person I will work with, me and Mary closely, who is a co-investigator on all our studies in Uganda, Dr. Noeli Nakasuja. Thank you so much. Thank you very, very much. There are several other people here that I really want to recognize, but you know, in the interest of time, I'll cut it short. But let me also recognize some of my former students. I know the dean is my former student. I was on a dissertation committee, but I want really to recognize Leila came all the way from Italy. Sometimes she's in Azerbaijan. So Leila is my former student, who is now at the University of Chicago as a professor there. So it's always good when you see your former students becoming deans and becoming full professors. And so it's always exciting. And then Susan, thank you for coming. Really, Susan is a colleague of mine from way back at Columbia University, where I spent my first 15 years. And you really, so I always tell my students that you build these relationships, they stay for life. So Susan, thank you so much. And she's still a colleague. And one of my trainees, my very first K trainees, Larissa, when I called, you said, yes, I'll go. And thank you so much. I first interacted with Larissa when she was at Johns Hopkins as an assistant professor. She's now a professor at UNC Chapel Hill. So I'll stop there. And but I just wanted to thank you for coming. And then I'll pass the program on to Osge and then to Prosi. These are my co-directors who will, you know, say a few words about CHILD, I guess.
Good morning, everyone. I just want to welcome everyone. We're super excited to have this event. We organized another special event, which is the Eclipse, to just happen on the day of our conference. And so you're all very welcome, and we look forward to a very exciting 2 days.
Good morning, everyone, and welcome to Washington University in St. Louis. Welcome to the Brown School. We are so honored to have you, and we look forward to Some a couple of days, others an entire week of fruitful conversations and discussions. So welcome.
So some of you, of course, you know, we are celebrating 10 years of over 10 years of officially being called CHILD, but we started over 20 years ago when we were being called SUBI, SUUBI, in the Greater Masaka region. Some of you who are here think that I'm from Masaka. I'm not from Masaka. I'm from Luero Triangle, but the only reason I went to work in Masaka is because of HIV and AIDS, and because my work is primarily focused on HIV and AIDS. In fact, the first time I went to Masaka was in 2004 when I was initiating my, program of research. And my people where I come from are always nervous. They say, the people in Masaka will never bury you, but that's where you have taken all the resources. And it's a big deal in Uganda to be buried, I guess. But there's a direct translation from my language. So, and I always tell them that I'm a scientist. I go where the problem is, and that's why I work in Masaka. But really, iChad started with about only $3,000, literally about $3,000. We are now a multi-million-dollar, I would say center, which is heavily funded by NIH, heavily supported by the university. So we are extremely grateful. Dean May reminds me that our recent grant, which went in, I just got a perfect score, and we're extremely great. Yes, so that's another 5 years of doing work in Uganda. So we're extremely grateful. Now, they have told me that I'm talking too much. I need to introduce the dean.
I'm just a messenger.
Exactly. So at this stage, at this time, I really want to welcome my dean to give her welcome remarks. We have a bio, and so I won't read everything about our dean, Dorian Trout, but our dean is the NAIDOF Family and Centene Corporation Dean of the Brown School, and she's a professor who previously was also a professor at University of Southern California, which is another big university in California. That's where we got her from to come and serve as our dean here. Dean Dorian has been here for slightly over a year. It's coming to a year, something like that. Her research is around parents as teachers. She's one of the very first people who did this whole concept around telehealth programming. So by the time the Zoom thing came, she was already very well versed with that. So she was ahead of the times. Her program was named, the program was chosen as the named commitment by the Clinton Global Initiative and was selected the winner of the Gare Community Investment Open DEO Early Childhood Innovation Prize. So before I mess up the rest of the writing, I'll invite our dean to come and say a few words, okay? Thanks.
Thank you so much for that, Dr. Fred. Good morning and welcome. I want to give a special welcome to the Ugandan Minister of Health, Honorable Dr. Jane Ruth Acheng, and the Bishop of the Diocese of Masaka, Bishop Severus Jumba, who was delayed, but we want to extend our warm wishes. This is a very unique conference and program meeting for iChad's innovative NIH-funded research projects and training programs. And they're having real impact, and that's important to us at the Brown School. They're having real impact on children, young adults, and families, as well as early career mental health and HIV researchers in Uganda. So it's really a true honor for us to host this gathering here at the Brown School. As Dr. Fred said, I have known him for many years. One thing he didn't mention is that he left my dissertation in defense to go submit that SUBI grant that initially funded all of this amazing work. I still remember because it was back in the day when you had to mail them in. And he had boxes and boxes of drafts. iChad's work is vitally important to what we do at the Brown School, and indeed is a key pillar that supports our strategic plan, which is called Driving Equity 2030 In that plan, we are dedicated to rigorous science, but also to the to equity, diversity, and inclusion in that rigorous science. So what makes iChad so unique is that we have a director from Sub-Saharan Africa, and it's uniquely positioned to address the barriers faced by students, scholars from underrepresented backgrounds. To date, iChad has had over 30 Ugandan field and research staff have gone on to pursue their master's or doctoral degrees in the United States, and several have become independent researchers, as we've all been told here, including our own Dr. Praskovia. Hi, Dr. Prasi. iChad works with numerous additional master's and PhD students and researchers and assistants, and they've have nearly over 100 research training program participants from underrepresented groups. We also have a dedication to rigorous science through Impact with Foreign in St. Louis. And the beautiful thing about iChad is that they're currently preparing to be part of a large-scale transdisciplinary center whose mission will be to tackle the epidemic of HIV and AIDS right here in Missouri. Transformative education is another one of our goals with global teaching and research. And iChad, as you know, brings scholars and students from the field to the Brown School to gain hands-on knowledge. And finally, we're always concerned that we are engaging in mutually beneficial partnerships and transdisciplinary research. iChad works closely with scientists and partners across campus, including the School of Medicine, the McKelvey School of Engineering, the Sam Fox School of Design and Visual Arts. And so we are grateful to iChad for being such an amazing pillar in our school, but also giving us colleagues and students that we are so proud to work with every day. With that, I'd like to take the opportunity to introduce our provost, Beverly Wendland. As provost and executive vice chancellor for academic affairs, Provost Wendland is responsible for the academic enterprise across our Danforth campus. That's the campus you're sitting in right now. She sets the academic strategy for the university in collaboration with the chancellor and deans and faculty. And she convenes all the deans of major academic units. She is committed to academic excellence and scholarly activity and facilitates cross-disciplinary connections in ways that I have never seen a provost facilitate them before. So we are very honored to have her and her deep commitment to student learning and success to both undergraduate and our graduate students. I'd like to invite Provost Wendland up now.
Thank you so much, Dorian, and good morning, everyone. So pleased to be here with all of you. It really is an honor to be here as part of iChad's Global Adolescent Health and Economic Strengthening Conference and the culminating meeting of the CHILD-GRF Global Health Research Fellowship. Just last year, I was in this room celebrating iChad's 10th anniversary. I marveled then at what this group of people had been able to achieve in 10 years. And this year, I am again in awe of the work that you do and the progress that you are making. Your commitment and passion for addressing family-level poverty and economic instability continues to lead to healthier children and more financially stable families in sub-Saharan Africa. I want to take a moment to thank Dr. Fred Sowamala, known to most of you as Dr. Fred, who founded this center and moved it to WashU in 2017. I appreciate him fostering this opportunity. Yes. I truly appreciate him fostering this opportunity for global engagement and collaboration at WashU. I also want to thank his team and his co-directors, Dr. Praskovia and Dr. Ozge, for their efforts in this important work in this week's events. So thank you to them. So as Dean Traub mentioned, iChad's work started in 2005 with Dr. Fred's first NIH grant, SUBI, which means hope in Luganda. SUBI's aim was to refine and test the feasibility of a family economic empowerment intervention in Uganda that includes opportunities for asset ownership, development of future planning skills, enhancement of mental health, and reduction of risk-taking behaviors for children orphaned due to AIDS. That grant laid the foundation for iChad's 20-plus NIH-funded studies, and that number continues to grow. I find it fitting that what started iChad is SUBI, or hope, because that is what this center is all about. It is about creating interventions that offer opportunity, growth, health, happiness, and fulfillment of potential for so many children and families. It is about creating hope for a better future, a better world. iChad engages with scientists from across disciplines, including psychology, behavioral economics, psychiatry, medicine, engineering, biostatistics, and epidemiology across the United States and sub-Saharan Africa. Importantly, at all stages of their research, the iChad team works in collaboration and coordination with local community stakeholders. This includes policymakers, religious leaders, schools, clinics, and caregivers. In Dr. Fred's own words, it takes a village to conduct rigorous intervention research. That rolls right off the tongue, Dr. Fred. So far, it is quite a village. There have been more than 70,000 participants, community members, and partners who have been impacted by this work. The success of iChad's engagement is a testament to the importance of teamwork and transparency in addressing the complex challenges children and their families experience. It is also inspiring to me how iChad's mission epitomizes so many elements of Washington University's strategic vision detailed in our new plan Here and Next. iChad embodies distinction in research and education. It boasts over 20 NIH-funded research grants and 180 peer-reviewed manuscripts. Its research is global. iChad is a leading research center in global health at WashU. The work is transdisciplinary, both on and off our campus. iChad has active collaborations with partners from the School of Medicine, McKelvey School of Engineering, and the Sam Fox School of Design and Visual Art, and meaningful partnerships around the world. The outcomes you seek and the way you do your research is centered in equity, diversity, and inclusion. Every aspect of iChad's work focuses vulnerable groups, including children, as well as individuals and families affected by poverty, HIV, mental health, and other challenges. And you are committed to a pipeline to train and educate scholars and students from diverse and underrepresented backgrounds. And finally, your work echoes the university's dedication to community impact. iChad is creating new pathways to adapt its innovative studies to alleviate health and mental health issues facing vulnerable groups in the St. Louis area and other areas in the U.S. It is incredibly fulfilling to hear of your research and your successes, and to recognize that iChad's mission and vision only reinforces our bold vision for Washington University. Of course, another reason we are gathered here this morning touches upon another vital aspect of iChad's work, the center's commitment to mentoring and teaching the next generation of scholars. iChad is creating more structured and well-resourced opportunities for both young scholars from sub-Saharan Africa, as well as underrepresented minority groups in the United States. The center has secured NIH funding for 4 training programs, which have resulted in training 100 career researchers who are interested in child and adolescent health and mental health, health disparities, HIV, and other related issues. And they will be welcoming more than 20 new trainees later this spring. These programs have created vibrant and meaningful institutional partnerships, both in this country, in Africa, in Eastern Europe, and in Central Asia. And today, we are celebrating the accomplishments of the trainees from the Child Global Research Fellowship Training Program funded by the Fogarty International Center. They are medical doctors, lecturers, psychiatrists, and academics dedicated to child and adolescent mental health in the context of HIV/AIDS in Uganda. For 3 years, these 18 trainees have gained methodological research skills, professional development guidance, mentorship from experts in their field, and funding to deliver a pilot project. Over the next 2 days, you will be hearing from many of them as they deliver final presentations. I know that we are thrilled to celebrate their hard work and accomplishments and to support them as they move on to become effective and driven independent researchers. I want to offer my deep congratulations and best wishes to all of these fellows. Your passion and dedication to fostering well-being in youth, families, and communities are inspiring. You will change our world for the better. Now, to continue our program this morning, it is an extraordinary honor to welcome the Honorable Dr. Jane Ruth Acheng, Minister of Health of Uganda, to Washington University. Her commitment to supporting the work of centers like iChad is a shining example of how government officials can access data about what's working in their communities and then use that vital information to create policies that improve the health of a nation. And here to introduce our keynote speaker is Dr. Noeline Nakasuja, Associate Professor of Psychiatry and Head of the Psychiatry Department at the College of Health Sciences at Makerere University and a co-director of the CHILD-GRF program. So Dr. Nakasuja, welcome.
Thank you very much, Dr. Beverly. I'm extremely excited this morning. I have been coming here for a full year. I started traveling last year in April to come and attend the 10th anniversary of iChad. Unfortunately, visa issues delayed that process, but I'm very glad that I'm here today and that I happen to come on a day when the sun is also eclipsing, or the moon is eclipsing the sun. So I'm here to introduce the minister, my Honorable Minister of Health, Uganda, but I want to say a few words, and I'll not take too much of your time. I will not take too much of your time. So while Professor Fred says he's not from Masaka, I will say I am from Masaka. But I don't believe that I'm on part of this collaboration because I come from Masaka. Professor Fred looked for me in Makerere University because I don't know how he got to know, but realized that I have a yearning for training, for mentoring, for creating a future group of individuals that are interested in research and the well-being of our country, and we believe in quality. That opportunity only came, I've been training, but to have a collective group of individuals that we have to train from various fields came through the opportunity that was offered by Dr. Fred Sewamala. I didn't know he had just moved to Washington University at the time that he started looking for, collaborators in Uganda. And I'm so glad that he landed on me. I know he must have looked for other individuals, but I'm glad that that opportunity came towards mental health. So while we have a limitation of resources through the services that are offered by the ministry in Uganda, mental health is one of those that really is lacking, both for service provision, in the various units that are within the country, but also for the human resource, and worse still for the research and teaching and training. So to get the opportunity to have and create a bigger number of individuals in that field is extremely an honorable, position that we have with this collaboration. And I'm hoping that the CHILD-GRF trainees that have been on this program will continue to grow. You've been mentored by the best. I believe you'll get to hear from the students through this two-day program, sharing their experiences. And when I say the best, I mean both the Ugandan mentees we have, rather mentors that we have, some of whom are in the room, Professor Byachika, Dr. Mujisha, and others who are on their way. They're delayed only because of their flights. But also for the group of individuals that we have had trained, we believe in you. We selected you because we believe you. And we're excited for how far some of you have already come. So now I will turn and talk about the minister. So the minister, Honorable General Fachengo Chero, I have known for a long time. He was my senior during training. She's trained as a pediatrician, but has worked, through all the ladders that are in the ministry. She's worked as a medical officer, senior medical officer, medical superintendent of a hospital. She's been through all of it. She was also the Director General of Health Services before she became the Minister for Health, a position she's occupied for quite a long time. I don't know how you do it. She's never shaken off, even when there are reshuffles, she's still there. And I believe that is because there's probably a vote into what it is that she does in the services that she delivers. We have resource constraints, but she argues for us in Parliament to see that the best can be delivered even with the limitations that we have. Right now, we are doing a yellow fever vaccination campaign, and she was in the papers for that. And in Uganda, we want to have a, yellow fever-free country, like most other places. And the other one thing I want to say is for the support she always awards towards training programs. I have recently been the president for the Uganda Society for Health Sciences, a group of scientists in Uganda that look into research and offering training opportunities here and there for, the Ugandan who usually misses out on this. And she's always supportive for those meetings. She's a member of that society as well, but her coming to those meetings really gives a lot of should I call it strength, but a belief for all others to see that this is the way to go. And for the CHILD-GRF programs, she's always come each time that we invite you. Thank you so much. You're very busy, but still you always spare time for us. So we believe that this is something, I know we're talking about children and that you love for children to be promoted, but I guess if you get the right footing for a child, then everything else will, go the right way. So without much further ado, I really welcome you to this meeting and invite you to give us your keynote. Thank you very much.
Thank you very much, Professor Noelin, for your very kind words. It's a long protocol. Perhaps it will also give me opportunity to see the people who are part of the protocol. The Provost and Executive Vice Chancellor for Academic Affairs, Beverly Weldland, Vice Provost of the Interdisciplinary Initiatives, Mary McKay, Naidoo Family and Centered Corporation Dean of the Brown School and Professor Dorian, the Right Reverend Bishop Jumba of Masaka Catholic Diocese, who is not yet here with us, the Research Compliance Technical Team representing Ugandan government, including the Uganda National Council of Science and Technology, ICHAD researchers and collaborators, researchers and leading academicians here present, the early career global health research trainees and scholars present, and my entire team from Uganda. That includes you, Professor Noeline and Pauline. You may be on the other side, but when I'm here, you belong to my team. Well, good morning to all of you. Before I give my speech, allow me in a special way to appreciate you, Professor Fred, for inviting me here. It is my first time in Missouri. I have visited other states, but this is my first time here. And also in a special way to appreciate my sister Stella, who made sure I got on that plane. I had a lot of excuses, but both of them put pressure on me and said, if you love and appreciate ICHAD in Kampala, then you just have to extend it to the other side. So thank you very much. I bring you greetings from the Ministry of Health, Uganda, the entire team. They appreciate the work that ICHAD is doing in Uganda, and they are very much aware that I am here because of that work. So greetings from the Ministers of State, from the Permanent Secretary, and from the Director General. And of course, I bring you greetings from my family. Right now, there is no one in my house because I was the only one at home. And when I traveled, the house is empty, but they send you their love. I came with my PA, George, who is right over there. You already know Stella, and one other technical officer who was delayed at Chicago. I think there was some mishaps. She'll be arriving later on today, Doreen. So thank you very much for this opportunity to speak a little bit about ICHAD, the ICHAD we know. It is a privilege to be standing here in this historic Brown Hall at Washington University in St. Louis. And it is true what Professor Fred said earlier on. When we read Washington, in our heads, it was Washington, DC. That's why yesterday I asked you several questions, why this university was named Washington. I still need an answer. To bless the Global Adolescent Health and Economic Strengthening Conference and the NIH-funded capacity building CHILD-GRF program final meeting. I have been informed that last year, the International Center for Child Health and Development celebrated its 10th anniversary under Dr. Fred Sewamala's leadership in this very room and commemorated ICHAD's decade of growth and accomplishments as a high-impact global health and social development research center in Uganda and here at Washington University in St. Louis. Although I was not able to attend the celebrations at Washington University in person last year, our government was represented by Dr. Agnes Sevowa from the Ministry of Health and several officials from the Ministry of Gender, led by Commissioner Mondo Chateka. This is a very impressive group that I am sure adequately represented our country. While I could not participate in the 10th year celebration held here, I ensured that I attended ICHAD's Forum on Child and Adolescent Global Health Research and Capacity Building, held in Kampala in June 2023, as mentioned by Professor Noelin, during which I had the opportunity to join the 10-year celebrations and highlight our ministry's priorities and underline the importance and alignment of iChild's work with the Ugandan Ministry of Health and government policy initiatives. Children and adolescents in sub-Saharan Africa and Uganda face multiple intersecting obstacles, which too often prohibit healthy development and realization of future opportunities. We have a big percentage of children in Uganda who still live in poverty, anywhere in the neighborhood of 38%. Unfortunately, the recent COVID-19 pandemic did not spare us as a country, further exacerbating the health and mental health challenges in our communities. Though the circumstances facing vulnerable children and adolescents sound dire, we know that Uganda is a strong country, and frankly, sub-Saharan Africa as a region where Professor Sewamala's and iChild's work is concentrated is a resilient region that has overcome adversity before. Many countries in the region had to fight for their political independence and self-governance in the 1960s, 70s, and as recent as the 1980s. Even then, they have risen stronger. Specifically for Uganda, we want to appreciate His Excellency President Yoweri Kaguta Museveni. Our government was instrumental in confronting the HIV/AIDS epidemic when it hit the country. As many of you may know, Uganda was among the first governments in sub-Saharan Africa to advocate for policies and programs that were effective in reducing the HIV prevalence, since we were at the forefront of several policy initiatives in the region, including the HIV/AIDS epidemic and the initiation and implementation of universal primary education and universal secondary education. Uganda is excited to once again have the opportunity to lead in addressing an extremely important issue for the continent of Africa. That is a low supply of trained researchers on the African continent. I am aware of the fact that we have some of the strongest brains in this room. But allow me to share with you a few facts which you may or may not know. Number one, a 2017 Lancet report found that only 35% of scientific publications addressing research interventions in low and middle-income countries include authors that are from and work in low and middle-income country settings. Two, few African scholars on the continent are able to compete for extramural funding for their research program, primarily due to a lack of infrastructure and a lack of investment in training the next generation of investigators. And three, most research interventions for sub-Saharan Africa, including those that many of you in the room are focused on, are still guided by theoretical models originated in the global north, lacking cultural congruence and sometimes contextual relevance. Against that backdrop, there is a need to build research capacity addressing health disparities affecting children, adolescents, and their families. I understand that is what part of iChad does through its 4 training programs by the National Institutes of Health in the United States, including Achieve and CHILD-GRF, both funded by Fogarty International Center in partnership with the National Institute of Child Health and Development. The Researcher Resilience Training Program, funded by the National Institute of Mental Health, and the LEAD Global Program, funded by the National Institute of Minority Health and Development. Since 2019, these training programs have provided rigorous research training and career development support to more than 120 early career researchers with a focus on child and adolescent behavioral health in low resource settings, including 40 from Uganda and 20 from other sub-Saharan countries. This is commendable. In fact, during this conference, we will hear the work of early career investigators from all 3 cohorts of CHILD-GRF and celebrate their accomplishments and graduation from the CHILD-GRF program. The majority of the trainees or global fellows in the iChad training programs hail from and/or focus their research on sub-Saharan Africa. This region continues to be disproportionately burdened by numerous pervasive communicable diseases and non-communicable diseases. As a region, we face multiple health challenges affecting our children, adolescents, and their families, including existing endemic diseases like HIV, tuberculosis, and malaria, emerging and re-emerging infectious diseases like Ebola virus disease, Marburg, and others, the increasing incidence of non-communicable diseases like nutrition deficiencies, cancers, and mental health, as well as a set of exacerbating factors that include the rapid population growth and poor environmental health, all of which contribute to poor public health and an increased overall disease burden in the region. Furthermore, sub-Saharan Africa remains the world's most affected region by the HIV epidemic. Depending on the report or data you want to cite, the sub-Saharan African region is home to 71% of people living with HIV worldwide, with the epidemic continuing to spread among young people, although we are looking forward to ending AIDS by 2030. I believe it's possible. Importantly, factors leading to health disparities in sub-Saharan Africa, e.g., the weak healthcare systems, including inadequate research, surveillance, and laboratory capacity, scarcity of public health human resources, and limited financial means, have been further aggravated by the increasing burden of emerging and re-emerging infectious diseases, such as the ones I have mentioned above, including Ebola and the severe acute respiratory coronavirus, COVID-19, that has caused the global pandemic. In Uganda, one of the focal countries for the training and research programs at iChad, while efforts have been made to increase research capacity in recent years, including a partnership between Makerere University and several universities in the global north, including Washington University in St. Louis, the institution hosting us here, several of these emerging collaborations are relatively new and could benefit from additional external supports. Moreover, additional opportunities should be in place to foster South-to-South collaborations and exchange of expertise to further enhance capacity building from within the African continent. While medical, lab, and clinical research is of utmost importance in basic science, it is equally important to study social dimensions of public health issues, including, but not limited to, social determinants of health, health services research, and treatment-seeking behaviors. I understand the training programs championed by Washington University's CHILD and funded by the US government through its National Institutes of Health do exactly this. As a medical doctor, no longer practicing, well, I practice policy, which is also very important. Policy and politics run the world. Yes, but medicine keeps us healthy. So whichever direction you choose to go, we are still contributing. As a medical doctor, I know that current biological approaches to health and disease are primarily used to inform the development of curative and preventive interventions. Yet psychosocial, structural, and cultural factors are critical aspects of health and significantly impact health outcomes. While these factors are widely acknowledged in research literature, they are not effectively utilized to inform healthcare and public health due to limited communication between medical and social behavioral scientists. It is therefore critical to train the next generation of researchers who are well-versed in working with multidisciplinary teams and communicating across disciplines to optimize health outcomes for populations. Again, I understand this is part of the focus across CHILD's research training programs. This is why we are honored that Uganda is playing a key leadership role once again, this time not only as a host country for the Summer Training Forum, but also by implementing many research projects, including CHILD's innovative applied research that has important implications for our policies and programs. Uganda is privileged to host several rigorous studies of utmost public health relevance funded to CHILD by well-recognized institutions like the US National Institutes of Health, generating new evidence and informing the public health field, all generated in Uganda. In fact, as I mentioned earlier, CHILD currently houses 12 research studies funded by the National Institutes of Health, all of which have demonstrated important positive health and mental health outcomes for our youth and families. Indeed, CHILD's work and dedication to the well-being of children and families impacted by poverty and disease in sub-Saharan Africa is simply awe-inspiring. I am moved by its impact and approach. Congratulations to you. As mentioned earlier, CHILD's work closely aligns with the policy initiatives and priorities we have set at the Ministry of Health, Uganda, including 3 thematic areas, namely 1, health promotion across the life course, including reproductive, maternal, neonatal, child, and adolescent health, and addressing the social determinants of health. 2, non-communicable diseases, prevention and control, and 3, communicable disease prevention and control. Our engagement with ICHAD and its work started back in 2016 when the Minister for Education, who is also the First Lady of Uganda, Honorable Janet Kataha Museveni, launched the Smart Africa Center, co-directed by Doctors Sewamala and McKay at the first Child Behavioral Health in Sub-Saharan Africa conference. During her keynote speech, she emphasized the importance of addressing child mental health in health programming and voiced the government's commitment to developing a solid policy framework for the betterment of Ugandan children, working in tandem with colleagues across the African continent. Upon her return from the conference, the Honorable Janet Museveni emphasized great enthusiasm about ICHAD's work and its potential to inform policy initiatives at the national level. It was also in 2016 that I met with Professor Sewamala in my office and engaged in discussions around child and adolescent mental health needs. Now, some of you may see 2016 as very long ago, but like Professor Noelin said, I have been around for a while. I may be the longest serving health minister currently. The truth is that the political terrain is fluid. You are here today, you're gone tomorrow, but somehow I have been there. And God willing, I will still be there to continue supporting ICHAD. Since then, the Ministry of Health has engaged with ICHAD and its research in various capacities, given our commitment to evidence-informed policies. In 2017, Professor Sewamala and his colleagues met with then the Speaker of the Ugandan Parliament, the Right Honorable Rebecca Kadaga, who is currently our first Deputy Prime Minister and Minister for East African Affairs, and over 20 members of Parliament representing several parliamentary committees such as health, education, gender, social welfare, children and youth. They discussed the possibility of the ICHAD team working with the Parliament of Uganda to design a child and adolescent mental health policy for the country and to collaborate on other health and education-related issues. This meeting resulted in a follow-up meeting with the chairperson of the Uganda Parliamentary Forum for Children, as well as an invitation by the Parliament for ICHAD to contribute to the Mental Health Care Bill, which is now an act of Parliament. You might be interested in following up to ensure its implementation. As a result, ICHAD submitted a 3-part policy brief on child and adolescent mental health in Uganda, comprised of prevention and early intervention, workforce training and mental health, poverty and asset development. This helped to inform the drafting of the current Mental Health Act. The Ministry of Health and Washington University have drafted an MOU to guide our partnership moving forward. We are committed to supporting ICHAD's work with a dedicated staff within the Ministry of Health who will work as a liaison between the two institutions. Details are currently being worked out between Professor Sewamala and ourselves, and I do hope that we can begin sooner than later. All in all, All in all, we in the Ministry of Health and in government are truly excited to bring together this global team and to build the knowledge and talent of our Ugandan and African researchers who will carry this work forward for the future of Uganda and Africa long after we are gone. But we are not yet going. On behalf of the Ministry of Health and the government of Uganda, allow me to express how proud we are that Uganda is taking the lead on these initiatives, which are so imperative for the future of Africa as a continent. And we cannot wait to hear and read about their progress as these training programs and research projects move forward. I also acknowledge that sustainable and scalable change is not possible without partnerships between researchers and policymakers, both local and national. As a government, we greatly value evidence as we formulate policies and programs to improve the well-being of our children, families, and communities. I would like to applaud Professor Sewamala and ICHAD for their tireless efforts to engage with the policymakers, both at the local and national levels, and communicate the results from their rigorously designed research studies. Thank you very much. It is of utmost importance for researchers to develop skills, to work closely with policymakers and learn how to effectively communicate their research findings for the development of evidence-informed policy. On behalf of the Ministry of Health, the government of the Republic of Uganda, and on my own behalf, I welcome you all here and appreciate you for contributing to global public health and to the well-being of our children, adolescents, and families in particular. We depend on the innovative work and science that you all do and the new generation of scholars in this room will do to improve and or save lives. Working together, we can improve health outcomes for all of us, including young people and families across the globe. Thank you very much for your dedication. Allow me also to appreciate my teams from Uganda with whom you collaborate very well. Thank you for coming. Professors Noeline and Pauline. And my teams, this clearly indicates the importance that you put to this collaboration. Lastly, let us join together to contribute innovative solutions so that we can provide a better future for our children and families in Africa. I thank you for listening to me. And I thank you for the good work that you are doing. God bless you all.
Yeah, so Honorable Minister, before you sit, we would, first of all, would like to thank you so much for the collaboration, many years. Of course, 2016 is not very far, but 2016 is far enough for us to remember that, that was even before COVID. But for your commitment, I want to give you something very small that you take back. A small from Washington University. we know we read a lot of newspapers, we are always in the papers, so we'll hold the papers. Yes, that's the university stuff. Yes. And the judge, so you can have this. Yeah. Thank you very much. Okay, back to you guys.
Thank you very much, Dr. Fred. Thank you very much, the Honorable Minister, for your very kind words, gracious words, your words of wisdom. So now I think it's the time most of us have been waiting for. We'll take a break, coffee break. So if we can all come back at 10 o'clock. 10 o'clock, let's reconvene here to continue our program. Thank you very much.
All right, so our next event is supposed to be a panel, the Effective Community Collaborations and Research panel. However, it's going to be a Q&A because most of our panelists are kind of stuck with delayed travel. We had bad luck this year with flights. So we're very honored, though, to have Ms. Stella Ayo Adongo join us and talk about her experiences from a couple different perspectives and capacities working with effective community collaborations and research. And our moderator will be Dr. Noeline Nakasuja. So I think Dr. Noeline will do a brief introduction and have some panel questions, and then we'll open it up to the audience for Q&A. And we will just adjourn right at 11 because it'll be probably a shorter conversation than if we had 6 people on the panel. And then we'll just keep on time. So thank you so much, Dr. Noeline, Ms. Stella.
All right. So welcome back from tea break. We were supposed to have had 3 panelists. And before I get into introducing Ms. Stella here, I'm going to choose a bishop in the audience. And I'm going to also choose a laboratory technologist in the audience. You can't hear me? You can hear me, right? Yes. So even though we will open it up to discussion, be prepared. I will not tell you who the bishop is and who the technologist is, but I'll just throw the question to you. So be ready for this very interesting panel discussion that is supposed to look into effective community collaborations in research. The reason we had a bishop as well as someone in the lab, as well as someone that is in the community, is for us to have an effective engagement on what it takes for one to do research in the community. And as you know, all these 3 individuals contribute and are important players for such work to get done. So Ms. Stella here, that I'm seated with or honored to be seated with this morning, has over 25 years of progressive experience in strategic leadership, development, management, and program operations. She's a child rights, child protection, social policy expert, and an advocate for social justice. She has been thought leader in child rights discourse, providing strategic leadership and governance and management levels, and is currently a board member of the AfriChild Center, Action Aid International Uganda, and Uganda Child Rights NGO Network. She's held leadership positions at national, regional, and global levels, and has served as director for pathfinding countries, global partnerships to end violence against children hosted by UNICEF, and has also been director of the African Partnership to End Violence Against Children and the director Uganda Child Rights NGO Network. She's done a lot of things, as you can hear, but all of it geared towards protecting children. She has extensive knowledge and experience advocating for vulnerable groups such as children and the youth and the elderly, I'm also very interested in the elderly. So we'll start a conversation on how to protect them, especially as Uganda's life expectancy continues to grow thanks to the Ministry of Health with the provision of health care that's making people live longer. HIV being one of the things that has helped, HIV control being one of the things that has helped to improve life expectancy. Ms. Stella is a visionary and has demonstrated in the founding of national and regional level movements for social justice, such as the Africa-wide movement for the children, all of which have made significant contributions to voicing issues of the affected. So, Ms. Stella Ayo Odongo, you're very welcome to this one panel discussion, but we'll have the audience joining us a little later. So the first question that we have for this morning is to ask, in what ways can community-based research collaborations contribute to building sustainable and resilient communities, especially in regions with limited resources? So you've done a lot of work in these areas. What are some of those experiences that you would wish to share with us this morning?
Yeah, thank you very much. When you're introducing me, I was looking over my shoulder to see whether there was another person you're speaking about, because it is quite overwhelming, but thank you for the warm introductions. And like the bio has said, I have been involved in this sector, working with and for children for the past 25, coming to 28 years. And for the record, I keep saying I'm 16, so don't look at that age. I'm 16 for the record. So over these 25 years, I have had engagement at community, national, regional, and global level. And one lesson that emerges is the importance of evidence and research to inform whatever actions that we do, to inform programming, to inform policy, to inform legislation. I will start with an experience. I was in one of the many engagements. I was in a community meeting, and one of the parents asked, because I think at that time they had mentioned that there was a global conference. So I had just come back from a global conference. So one of the community members put up her hand and asked, so all these conferences that you go for, how does it change the life of a child? Now that got me thinking, because it was a clear indication that the people at the grassroots do not see the connection between what we do when we come for these conferences and the work that they are doing. So that brought to my mind the importance of involving them right from the beginning, not only just for the conferences, but even for the research. I know we have many researchers in the room here, and many a time we focus on what it is that we want to get out for our PhDs, for our master's thesis. And you've written the proposal and you're saying, okay, which district should I go to? And then you determine the district you should go to. But serving on the board of AfriChild, we've gone through programs and received documents from the community. And one thing that I learned from them is that action-based research and learning that is informed by the community is very, very important. Because one of the programs that AfriChild runs has involvement of the community. So they go down to the community, involve them in the design of the research proposal, in the formulation of the research questions. And by the time that you're getting to do the research, the community is not just a recipient of what comes out of your research, but is also a partner in generating the questions and all. So that is very, very important. So community plays an important, once you involve them, there's ownership. Right from the beginning, they know what it is, and then they also participate in the implementation. That is the second level. The other level of community involvement, again, when we talk about community, and I'm glad that in the opening remarks it came out, that it is not just about community in the villages, let me use that expression, but also the community of practice around us. How do we involve policymakers like the Honorable Minister here? How do we involve parliamentarians, the legislators? Do we wait for us to go with our information and say, we carried out this research on child poverty, and this is what the impact it has, all for them to adapt and cause the change, we need to involve them from the beginning. Do you know, we have an idea. We want to carry out an engagement on changing policy and legislation, and it's relating to poverty. So we want to hear your views, get them involved from the beginning. So from my experience, that is what has been. Thank you.
Right, wonderful. So one of the main things you've mentioned was you said something about action-based research. What exactly did you mean by that?
Action-based, action-informed research is research that is or practice-based as well, that is informed by what is happening in the by what is happening in the community, but also involving the actors in the community. The proponents or those who are in the community are the ones that take the lead. It is not me who goes to the community and proposes what is going to happen there, but we work together and design the research with their involvement and their input in whatever it is that is coming on. So they actually determine the direction of the research. They will even be able to tell you, you know, this is not going to work for us. These are some of the questions. The members of the community are not going to respond to this. This is going to be the one. So that is what I meant. Yeah.
I see. So you've done a lot of work, you know, given with the way I introduced you. So what some of the programs that you've had implemented, what has led to their continuity in the communities that you've set them up, if you followed up some of them?
One key thing is ownership. Ownership right from the start, and ownership does not just happen at the time when the project is, when you win the grant. Let me use a grant as an example, but ownership starts from the time you conceive the program. One of the programs that I worked on for a long time was the issue of increasing retention of girls in schools. And a key factor that was hindering girls, causing them to drop out, was lack of the absence of sanitary towels. So we undertook a study, and one of the things that emerged was that the girls were actually dropping out because of the lack of sanitary towels. So what did we do? We got the private sector, shared the outcome of this study with, and then the private sector agreed that they were going to partner with the community, not to bring exotic, let me use that word, exotic pads from the factories, but to work with the community to use locally made local resources to make the sanitary pads. So then, rather than invest so much time and so much money in buying, they were then using the resources that were there. And that is how the sustainability happened, that it was possible for this organization to teach the girls, and that is how the sustainability happened. First, we got the evidence of what was causing them to drop out. Then we got what we can work with within the community, and then use that as a way of making low-cost sanitary towels that then ensured that some of them stayed in school. Of course, in the long run, we brought on board the private sector, and we saw that the private sector also invested in that. So that is it.
Wow. So sometimes even, you know, stuff that may be considered as simple or, you know, low cost can really be something that impairs someone's being able, you know, to rise. The embarrassment of, you know, getting up from a seat for ladies and, you know, your skirt is wet with the patch really throws off many of these children from being able to attend school. So other than the ownership, you know, of course, the players themselves, and you may use this or any other of the projects that you've worked upon, what else ensures that, you know, whatever program you've started in these communities continues way beyond after you have left?
The other one is advocacy and influencing. Mm-hmm. That is one of the things that probably has worked from where I have been. I remember a couple of years we were working on the Uganda's national, there was a national poverty eradication action plan, and they were now transitioning from the poverty eradication action plan to the national development plan. And so we're seated in the room with a lot of ministers, ministry officials of finance, ministers of finance, and they were talking about our point was to push the issue of children, child well-being and child protection into the National Development Plan. So the Minister of Finance does not understand psychosocial support. So the first question that the director asked me was, why do you think psychosocial support is important? At that time, we were dealing with the conflict in the north and the effect of the war. And then we tried to explain. And then he just threw his pen down and said, for as long as you cannot give me how many kilograms of psychosocial support a child gets, I'm not going to include it in the budget. And that was it. That is how it got out. And so we felt that we needed to then begin speaking the language of economists. So then we came up with what we call the cost of inaction. So we wrote a paper, a briefing paper, out of the evidence on the cost of inaction. And the cost of inaction was showing if we do not invest in child protection now, this is what it's going to cost. You're going to spend more on prisons. You're going to spend more on security because you're going to ensure that you guard many people. You're going to spend more on other things. So it's important that you prevent now and ensure that happens. That doesn't happen. That was my first encounter with the policymakers. The other one was a bit of a strange one because we were already running. For those of you who live in Uganda, Uganda now has a national child helpline that has been running for the last government-owned for the last 10 years. But we started working on that helpline in 2003. And 2003, I was working as an executive director of a network. For me, I did not have any interaction with children. It wasn't my business to interact with children. All I did was look at documents and policies. So I'm seated in the office, and then a woman walks into the office with a child. So she starts explaining her problem. And as she's explaining, then the child coughed, and there was a pool of blood in my office. And so I stopped, and then I asked her what happened. Apparently, the 4-year-old had been sexually abused by the father, the grandfather, and the uncle. So what came to my mind was that if this woman had where to report, she didn't have to look for any organization. So the reason she came to our office was because it had Uganda child rights. So then I looked out for what we could do. If they had a reporting mechanism, she would not have to come there. There's need for a confidential reporting mechanism. And that is when I spoke to Uganda Telecom at that time, and they gave a toll-free number. It was a long process. We had to talk to the Minister of Children then, present the case, again writing, because for me now that was the evidence. Again, I'm bringing in the importance of evidence. Evidence does not have to be rigorous research that like doctor does. It doesn't have to be like you do at the university. Anything that you can document that shows a need or a gap in a service would be evidence. So together with the Minister of Children, then we wrote a paper that translated into having a national helpline. At that time, the numbers were long. And I want you to write this down and see if a child can remember. 0800 0800 111 333. The second one was 0800 111 222. Now, this helpline was supposed to be a rescue mechanism for the child. Any child in need of help or at risk of abuse was supposed to call this line. And we had those numbers. So that was a good start. Now we had another hurdle to ensure that we get a shorter number, but it was impossible to get a short number until Uganda Telecom themselves experienced the problem. They had a call center, and the call center number was 333. So one of the nights, they're on duty, and then a child is calling. The child could only remember 333. So all the child would say, he's coming, he's coming, he's coming, and then the line goes dead. He's coming, he's coming, he's coming. And for about 2 hours, the child kept calling 333. So that is when UTL actually realized that these numbers are difficult for a child to memorize. And then we lobbied with the Uganda Telecommunications Commission, and we have now a short digit 116. for the protection of the child. So now it is a government facility. It is launched as 116. So that is how the journey started, from that to that. So it is basically saying that whatever we do in the workspaces that we do, generate evidence, the investment that iChild has, build collaboration and partnerships, either with the private sector or with the government, and then inform policy and inform action. The Child Helpline now is one of the only mechanisms that is included in the law and the child policy as a mechanism. So that is the journey that is started. So the point I'm also making is that for research to be effective, for the work that we do to be effective, we need to have an end in mind. And I'm glad that a lot of the things that we're looking at in the partnership that we're building between the Ministry of Health and iChild is to see how we can effectively generate evidence and knowledge to inform policy action, and as such, the bigger good.
Oh, this is really very impactful work that you're doing. And I have a client that was telling me about this helpline. That's the job that she does. And I'm very excited to know that it began with you. I had no clue that that's where it began. But the story she tells me of the children that call in, or the mothers or guardians of children that call in with, sexual abuse. I mean, they are very displeasing, very saddening stories of what continues to happen in communities. So, the things that you mentioned that can lead to a program being sustainable and impactful for that community are really key. But did you face, I know you've said you had challenges. It was a long story involving the minister and other people, but did you face any challenges in that path of trying to build a sustainable program for the community with this or other programs you may be working on?
Yeah, the lot of challenges, when you're dealing with issues of, and again, I'm talking children because that's where I have spent most of my time. You think it's innocent. And many a time when you talk health, you think that health is innocent. There's nothing political about health because you're just saving lives and that is it. And for me, it was just protecting children and that was it. And it only dawned on me and that was 2016, the Sustainable Development Goals were passed, and one of the things in the Sustainable Development Goals was to protect children from violence and abuse. And so we now started pushing for the Children's Act to be amended, because the Children's Act had not been amended for a long time, because there was a lot of need for the law to protect children. And at that time, Uganda was classified as in tier 3 in terms of trafficking. So we were a supply country, we were a demand country, and we were a transition country. So then we then were now pushing for the amendment of the Children's Act. Little did we know, we just said children, let them protect them, we need the law. Little did we know that there was some, and this is with due respect to the minister, there were some high-level officials in the government that were profiteering from adoption. So children were being trafficked through adoption, and to adopt a child in Uganda at that time, 2007, 2008, would take about $30,000. One child. And so that particular person was heading, had a law firm, and so was highly prominent and was holding the law. So his firm was sending out 200 children a year. So you calculate 30,000, 200 children a year, and they're going out, and a lot of them ended up with organ harvesting, everything that you're thinking about, sexual abuse. That was what was happening. So now we were now tampering with that. That is when I realized it was very risky to do child protection. We were followed, we were tracked, we were threatened to drop that law. If we do not drop the law, we're going to be killed. Yes, just the law. And for me, that was shocking. So I'm saying that there are challenges along the way. At times you don't realize how the business you're in until you step on some toes. But having said that, of course, there are also challenges of implementation. A lot of policies are in place. A lot of laws have been developed, and like Honorable Minister challenged us that we need to ensure that we follow it, the implementation, because there's a gap between when the policy is developed and when implementation happens. Those of you who have traveled in trains, you always hear the robot announcing, mind the gap, mind the gap. How many of you have heard that? So my message to you is, let's mind the gap between the policy and implementation. Let us also mind the gap between policy, practice, and implementation.
So while you may face challenges, at the higher level, was there anything that on the ground sabotaged, the stuff that you had started on the ground level?
There are quite a number. It's just that I have to scan through quickly speaking. At grassroots level, yes. It wasn't a challenge that sabotaged. It was a challenge that made me question whether we were making an impact. And at that time, that was the time I actually wanted to drop the career. Again, it was in the community in northern Uganda. At that time, it was the peak of the conflict in the north. And so we're doing this research, generating information on children in the armed forces. So again, as a country, we were listed by the UN Secretary General's report as being a country that has children in conscription into the army. So we're doing that study. But then that was not what shocked me. What shocked me was I came across a lady who had given up 2 of her children. And she gave them up, and then she was telling me, please, I want to get hold of my children. Now, she had given them up about two years ago, 2 years before I met her. And then she was saying she gave up her children because they were starving. There was no food. They were starving, and then she needed just money. She didn't want them to die. So she gave them away, and I think they paid her at that time in terms of dollars should be about less than $50 for the 2 children. Yeah, it was less than $50 because it was about 20,000 for her to give up her children. So now she was at a point where she said she misses them and she needs them back. So I asked her, so what happened? How did you, what pushed you? Said we didn't have food for days and the children are going to die. So rather than die, I gave them away, but now I don't know where they are and things like that. So for me, for many years, you've been working in this, and then you still come across a situation of a failed service. For me, that hit me. So that was one of the things that hit me at a personal level. Again, it points to a system that you see, we need social safety nets for every individual. Is that achievable? That again goes to poverty. Is that achievable? Yes. We've seen results of SUBI giving hope. And I'm challenging Prof, how can we stretch SUBI so that we don't hear this? How can we stretch SUBI so that poverty does not become the reason that a child is given away? That poverty does not become a reason that abuse happens. That poverty does not become a reason that a woman endures intimate partner violence because she has nowhere to go. How can we do that? Yeah.
Right.
I know I've done a bit of mambo jumbo, but
yeah, it's no mambo jumbo. So before we turn to the audience, and I mentioned there's going to be a religious person and there's going to be a lab technologist. So for whoever it is, prepare your response to whatever it is I'm going to ask. So I just want to know, why did you ever choose to go for children?
why did I choose? I don't know whether it was a choice. I think it was a career coincidence. I started my career out from university. Never did I think I was going to work in this, but then the study that I talked about, it was a USA funded study, and it was looking at why girls drop out. And then I realized that maybe that could be an area of interest. That is one. The second one is also from a personal experience. How many of you have heard about Idi Amin? Like, so I'm one of those who was a victim of Idi Amin because my dad was murdered when I was 3 and 4. And so I grew up seeing so many things. And again, growing up, you see discrimination, you see rejection, not only from the failure to survive. That is a different issue. For me, that was not an issue, but for me, is about the lack of community. So when I see, like, for example, the pandemic of HIV breaking families, wiping away the social networks, it breaks my heart. But again, I think the social networks were already affected. And I remember speaking to a conference and telling people that the worst thing to be an orphan is when you appear, even when you reach out to people, the first thing they look at you is she has come for problems. So I remember going to my aunt, my dad's sister, proper biological sister, and I just knocked at her door, and then the first question was, "What have you come for? I don't think there's food here. I don't think there's anything." So I just told her, "I just come to visit." "So who told you that we needed visitors? When you're coming, you have to let us know what time you're coming, how long you're going to stay. I don't think we have a bed." And so she rambled everything. And that time I was 11. So I said, okay, so how many of us are going through this because of the circumstances that we did not choose? And again, it points to poverty, it points to, so those are some of the things that, yeah.
And thank you so much for sharing. And I guess that's what iChad is about, empowering, economic strengthening to reduce on the issues of poverty. Though as an 11-year-old, I don't know how you could have been helped at the time, but hence the agenda for what it is that iChad does. So you've heard very well from Ms. Stella about, what it is that helps to build programs that are sustainable within the community. You need to first gather the evidence. You need to be able to form partnerships. You need to ensure that the communities where you work, people own this program by you developing whatever interventions you may have with these individuals. You have to continue to advocate at higher level, but also influence with anecdotal evidence. You don't have to have done 1,000 people, research sometimes to get this, and also to continue the journey. So you start the journey, please don't stop it halfway. When you start the journey, you have to see it, to fruition. And some of the challenges she has shared. So now I turn to you, the audience, and the priest in the community. Please tell us what you think are maybe things that will help with building a sustainable research in the community. The priest? The priest is at the back of this row in a blue shirt. Here. Paul, you're Paul or Peter? Yes, right, you even have a name of an apostle. So, from a religious perspective, just with the hopefully you're a religious person, but from a religious perspective, what do you think would help in building a sustainable program within the community?
I can give the answer.
Yay.
Yeah. Thank you. Thank you, Dr. Fred. My name is Peter Kalulu, and I'm a second-year Master of Public Health here at Brown School, and I'm from Uganda. The church, here I pray at First Church Congregational Church of Webster, and in Uganda I pray in a village church called Word of Life Church in Pakwach district. Yeah, so what can reverends do, or what can we do to ensure there is sustainability in programs? I believe church for most of the time are so much determinants of the success of a program. For example, I can give you during COVID-19, we believe that to some extent, church contributed to some hesitancies to COVID-19 vaccination because there was some misinformation about, is the COVID-19 vaccine safe for people to take? Or is it right for us to go for it? What are the religious norms and cultures, values that are related to all kinds of these beliefs? So I think partnering with church leaders, church members, talking to them, and we know very well that they hold a number of people in their congregation. For example, what is happening nowadays in Uganda, if you watch social media and the rest, you see different churches, they hold a big number of people, and not only politicians using them to influence their interest, I believe they can be used to also influence health-related interventions. So I think if they are more so intervened, they're talked to, they're engaged, I believe something can happen to sustain our project. Thank you.
Dr. Frey wants to say something, but I chose, this is the representative of the bishop who is delayed, but I believe he is ably presented the role that the church can do in helping to build sustainable programs. Dr. Fred, you wanted to say something?
Oh, yeah, sure. First of all, thank you so much, Stella. Excellent presentation. Thanks so much to our moderator, excellent moderation. I think I really wanted, I'm not a church leader, so so I won't comment on what you said, whether, in the church, I don't think when someone preaches, you don't question. So when they say, Jesus said, you say he fed 1,000 people with one fish? Yes, 1,000. So you don't question how was that possible. So I won't question. But really, I wanted to highlight a question you asked about reunification or children being given out simply because of poverty. I work in the former Soviet Union, and I've worked there with my former student, with Professor Leila. And Leila introduced me to this idea of, and she will speak, I'll give her this, so she will say something. And we wrote a paper about it. In the former Soviet Union, the way we define orphans in Uganda is different from the way the word used in the former Soviet Union. Because in the former Soviet Union, at least in some of those countries, when you couldn't afford to take care of your child because of poverty, you were allowed to take that child to an orphanage. And that child will be considered an orphan. And then that child has a father, a mother, and they'll go and visit them every weekend or every so often. But this child is considered an orphan. So it's purely because of issues of income, purely economics, which was playing a role there. And now we are working on studies in that place, using some of the lessons from Uganda on what we call family reunification. How can we empower these families economically so that they can take back their children? And UNICEF has recognized that. And I think we have people from SOS who are here. And I'm going to give you to Leila, so she will tell us more. But the issue of economics is extremely critical and extremely important in terms of being able to afford raising a family as a family. Leila, do you want to say? I volunteered. This is the one
Yes, exactly. So, and I will talk a little bit more about this during my presentation after lunch, but it was exactly inspired by the same idea that because of poverty, families who don't want to give up their kids, they actually have to. And I think it's so different from the concept of in the US when we see that kids are removed from parents because of maltreatment and etc. And I think the situation in former Soviet Union is different, and I think that applies to many other countries. When parents still very attached to their family, to their kids, they really want to contribute. And exactly as you mentioned, for the well-being of the child, they do something that is actually stigmatized by the society, right? That means they kind of almost looks like they abandon the child, but they think it's kind of better. And I think changing that environment on one side for the child, because for the child, it's still perceived that the parent abandoned me, right? And it's very difficult for the child to understand that the parent did everything they could in that situation. And that's why I think, when I will talk, we say that in addition to the economic part, we actually added the family strengthening part, right? To kind of change that understanding. But the economic part is very important because without addressing this issue, how do you bring back the child again to the same environment that led to the institutionalization in the first place? And I think that's why when I joined the SUBI project, the first one that started in 2007, I think that really inspired me to figure out how can we combine multiple services or multiple interventions, because it's not only one thing that causes some of the issues that you mentioned. So
Thank you. Thank you, Leila. And Ms. Stella wants to say something in return.
Thank you, and thank you, Prof, for tickling my mind to think about the situation of orphanages, and again, in the context of former Soviet Union. But then for us in Uganda, there was also the situation of orphanages. At the time when we were pushing, when we were talking about the trafficking and then adoption, we saw an upsurge. When I started the work many years ago, we only had about 30 orphanages in Uganda. By the time we were pushing for the law in 2010, 2011, we had 700 orphanages in Uganda. Out of those 700 orphanages, more than 70% were just a transit place for children to move out and go and be adopted. Now, the law that we strengthened looked at two things: alternative care, and I'm glad that we have SOS here. Alternative care framework. So we now have an alternative care framework. We even have an alternative care panel that is promoting local adoption, not international adoption, because inter-country adoption was now a problem where we were failing to track these children. So that is one thing that happened. And then we also now were adapting the deinstitutionalization program. We're learning from Rwanda. After the genocide, there was a lot of orphanages that were created in Rwanda. Then the government of Rwanda then went for a deinstitutionalization program and promoting institutionalization as a matter of last resort. Those of you who have read the Convention on the Rights of the Child, institutionalization is usually treated as a matter of last resort. So that is what the government of Rwanda is doing. And we have gone to learn from the government of Rwanda. And we also put it in the Children's Act and Children's Policy so that we do not have institutions where the children can be integrated within families. So there is that program as well. But again, poverty is key. If the family that is adopting the children or is taking on these children for foster care cannot afford, they'll not be able to do that. So it's a lot of integrated, intertwined many things. Right. I thought I should just add to that.
Right, thank you. So I also promised that we would have a lab technologist to give us a view into how you can have, sustainable, build sustainable and resilient communities. So I'm going to ask, I know there is one in the room who has direct experience with research in the field. I see Dr. Niall pointing that way. I'm going to point this way, and then we'll go to the other person that I think I know who they are. But first, I'll ask Dr. Harriet Ajilong on what challenges you think there can be from a laboratory perspective on having sustainable and resilient research activities. And you first tell us where you work.
Oh dear, thank you so much, Dr. Noeline. Thank you, Ms. Taylor, for that wonderful presentation. My name is Dr. Harriet Ajilong. I'm a pediatrician. I'm not a laboratory technologist, as Dr. Noeline has said. I'm also a lecturer at Gulu University. I'm so happy about what Stella has talked about building sustainable programs in the community. I just wanted to bring out my experience. As a pediatrician, we usually work in the pediatric wards, and one of the communities that I've worked, one of the programs I've worked closely with is called Love One, and what they do is they take children who are malnourished from the wards, and actually they go and take care of them, but with the support of the parents. They teach the parents what to do, although they do not do the economic empowerment that Dr. Fred has talked about. And I thought this is really something that is very good. Instead of giving them nutritional supplements from the wards, they actually take them to their program. And this is something that has been sustainable, especially at Gulu Regional Referral Hospital. So when she talked about ownership of these programs by the communities, it's actually one of the ways that we can actually sustain these programs, empower the people so that they are able to continue to give that kind of continuity as far as these programs are concerned. Because I know many of our programs are actually donor funded, but donor funding is not sustainable. It is usually short-lived, but what can communities do to make sure that this actually continues? So community empowerment is very, very key. So that's why I wanted to take it back to Stella and say most of these programs are actually urban-based. For example, the toll-free numbers. But we know that the problem is actually big, especially in the rural areas. We have teenage pregnancies. Some of them are a result of child abuse. How can we strengthen this away from the urban areas, away from Kampala, and go away a little bit further, especially in the rural areas where this problem is rampant? Thank you very much.
Thank you very much, Dr. Harriet. Now, we have a US soldier in the room, but I know she's done research in Uganda in communities, and I want her to give us a perspective of the challenges of building a sustainable research collaboration that she may have faced. Dr. Massimo Tumba, a few comments, and then we'll come back here. I don't know whether there are other soldiers in the room, but it's the only one I know.
Dr. Noeline, that is quite a remarkable professional transition for me. But I think when we think about building operations, my experience, especially in the arena of child development, because I've worked, for example, on sexual violence in Kalangala among children, it's thinking about really how do you work with those communities? Because oftentimes they have very different perceptions. And we talk about those cultural norms, those cultural beliefs that actually, for example, fuel sexual violence against children. And we always think about this as maybe it's just the families, but you're also going to find, for example, the people who are charged with protecting these children also embody those same attitudes. So how do you work with them to challenge those attitudes, knowing very well that you could potentially be locked out of that community because you're challenging the leaders within those communities? But how do you work with those systems? How can you involve the different stakeholders, bring them to the table so that you can all move forward in the same direction, thinking about the shared values, the shared goals that you have? And that can be quite challenging, but we found that sustained community engagement allows us to be able to help in that sense. So thank you.
Thank you. So work with these communities, work with them so that when you're out of, that community, the work that you started continues. So in the last 2 minutes, I'm going to give it to you, Ms. Stella, for you to give any concluding remarks as per this discussion.
Okay, thank you. Thank you, Dr. Noeline.
Yes.
And the Reverend and Bishop and then the Captain for those insights, and also the lab technician. Quickly, just to respond to your question, your concern about the child helpline. We transitioned the child helpline to a government-owned facility in 2015. At that time, when we transitioned it, it was we were receiving calls as NGOs. We were receiving about 70 calls per day. Today, the helpline receives 1,700 calls a day. And it has presence in 124 districts in Uganda. I think we're about 150, 149. So it has presence in 124 districts. The concept that we used was to have a layered approach, three-tier approach, where we have the call center at a national level across all telecom lines, which is toll-free. And then we have national level response mechanisms, which is the rescue team, and then we have the district action centers. So district action centers have it's situated in the probation office, and so the response is happening there. So, and we're promoting the number they are promoting. So I keep forgetting that I'm part of them because the number is now being promoted nationally. So it's now Sauti 116. And it's now there's now an integration because we realized there was a connection between violence against children and violence against women. So there's now a GBV connection to it. But I can tell you that the percentage from the 1,500, more than 80% are from children, and about 20% require urgent rescue. So that is one. My second one, you've given me 1 minute. My second one is to talk about a global prevention strategy that was adopted to help by the world after the Sustainable Development Goals were passed. The UN Secretary General passed what they call the INSPIRE strategies. I don't know if you've heard about INSPIRE. How many of you have heard about INSPIRE? Heard about INSPIRE strategies. And INSPIRE strategies is basically to help us deal with societal issues. It's focusing on violence prevention, but it is kind of like holistic and comprehensive. And INSPIRE is an acronym. INSPIRE, the I is for implementation of laws, that whatever we do, in the work that we do, laws are important. So we need to have the laws and policies implemented. The N is about changing the norms and values, because a lot of the things that are happening are driven by deeply rooted norms and values. There's the third one, which is safe environment. The S is for safe environment. The fourth one is parent and caregiver support. We know that a lot of these, whatever we talk about, whether it is poverty, whether it is violence prevention, it's important to address the issue of parenting. Then there's income and economic strengthening as the I, response services. When abuse has happened, there's response services. And then the E, the last E is the economic and life skills. So that is a global strategy that if you read and pick, time is up, I'm being shown the time is up. Is it me or her? I think it's the moderator, time is up. But just to wrap up, I think there's an opportunity for us to promote the work that we're doing as ICHAD to ensure that it doesn't remain within our circles. We don't just speak to the converted, that we take this beyond us. The evidence that we draw from Massacre should be able to inform programming in others so we can scale it up in other places. Thank you.
So ladies and gentlemen, I believe you agree we couldn't have had a better discussion this morning for this program, as well as the contributors from the audience. And I believe the fellows have also learned something in how to get things done within the community. I thank you so much for participating, and I'll hand over back to the MC for the day to take us to the next session. Thank you so much for your participation.
Thank you so much. That was very skillful convening of a panel of experts from a group of experts. And thank you, Ms. Stella, for your insights. I know that was you got all of our attention and shared some really important work. So thank you so much. We're going to keep moving on to our next event, which will feature Very exciting. Our cohort 3 of our CHILD-GRF trainees, in the past 2 summers, cohorts 1 and cohort 2 have given their final presentations on their pilot study work in the program. And so cohort 3, this is their turn. And, you know, you'll hear a range of study topics, and some might be reporting results and others are still gathering data, and we'll get to hear the whole story from each of them. So we're going to present 4. Dr. Nolene is going to introduce each of them. But to get us started, we are very honored to have Dr. Mary McKay here. She's our Vice Provost for Transdisciplinary Initiatives, and she's going to kick us off to welcome and honor our trainees.
Okay, are you hanging in there? Yeah, thank you so much. I enjoyed listening to the panel from the back. And so it is my job to tell you a little bit about the CHILD-GRF Fellowship. And this is important to us as a community, but if you're a fellow who's about ready to speak, you're gonna do great, okay? So let me tell you a little bit about this fellowship. CHILD-GRF is the official title of this training program is the Child Mental Health in HIV Impacted Low Resource Settings in Developing Countries Global Research Fellowship. That's a mouthful. And so the CHILD-GRF Fellowship was funded in 2020 by Fogarty International Center. And it's been designed to provide state-of-the-art methods training, mentoring, and hands-on research experience to promising early career researchers committed to research careers focused on addressing HIV prevention and the serious burden of child and adolescent mental health needs in the context of HIV. The overall expectation is to just pour whatever we can into you fellows to increase and strengthen and sustain the capacity for a research infrastructure in Uganda. And so that's why you are so important to the future of research, both in your country context and to the real meeting the needs of Ugandan children and their families. So those of you that have written applications for funding know that there's a lot of words, and they are completely guided by a set of specific aims. And I'm just going to tell you what those aims are that have guided our work in CHILD-GRF. The first is to identify and train you, the fellows, 18 scientists to be exact, from Uganda, and to keep recruiting year after year. And we think that you're special. We've identified you as capable of serving as a principal investigator on both your own studies, but also we think that you're on a trajectory where you can actually submit your own grant applications to fund studies in the future. We also wanted to make sure that you didn't feel that you were by yourself. And anybody that's mentored by Dr. Nolene never feels by themselves. And but we wanted to really put you as part of a network of committed mentors from the global north and the global south to ensure that you met, that your training needs were met. And and then finally, we wanted to study ourselves and try to figure out every year what we could do better as mentors so that we could actually help you on your way to make a real difference in the lives of children and families. So CHILD-GRF has accomplished a lot. And so I just want to brag for just a moment about the work that Dr. Nolene, Dr. Fred, you have done in CHILD-GRF, along with so many of you in the audience. So we've recruited our 3 cohorts, 18 total early career scientists from different institutions across Uganda. Over the course of the program, in a set of very short years, you produced 73 publications, 44 conference presentations, and 12 funded grants across your 18 trainees. It's a lot. We are incredibly grateful that we partnered with an extended network of mentors in Uganda, many of whom that are here today. And so if I call your name, Dr. Avan, Dr. Allen, Dr. Anita, Dr. Agata, if you are in the room or not, please thank those mentors for us. So now it's time to celebrate our trainees, your accomplishments. And so I really feel so very proud to call Dr. Nolene to come back up and introduce our trainees. Thank you very much.
Yes, one of the things that we've practiced is to how to shrink your data and present it in a very short time. So we practiced with 15 minutes and I'm shrinking them by 3 minutes for you to fit within 12 minutes of each of your presentations. And then we'll have a Q&A at the very end. So the first person that is going to speak to us this morning is Dr. Edgar Guma. Dr. Edgar Guma is the head of psychiatry with the General Military Hospital in Bombo. He's not a soldier like the other one. This one is just the head of psychiatry, and also currently works at the Naguru, one of the hospitals within Kampala, Naguru Hospital. Dr. Guma, please come and let us know what it is that you're doing.
Thank you. Thank you, Professor Noeli. Okay. All right. Good morning, everyone. My name is Guma Edgar Innocent. My name is Guma Edgar Innocent. I am a psychiatrist and mental health researcher, and also the head of the mental health department at Bombo General Military Hospital, as has already been said. I'm overjoyed to be standing here today, but also very anxious to, to be presenting to a group esteemed as this, to the Ugandan dignitaries, our program directors, for the different training programs, ICHAD leadership, WashU leadership, and all protocol observed. I am really overjoyed to be standing in front of you. So I'm going to tell you a bit about what I've been doing for the program, and I'm glad that it has followed the panel that Ms. Stella was on, because my research interests actually lie in the same field. And I know I only have 12 minutes, but it's a lot of work. Please allow me to speak as fast as I can so that we get through everything. Okay, first slide. Yeah, no, first slide. Okay, so my mentor through this work has been Dr. Dickens Akena. I think you had some delays. He's not here yet. I was hoping you'd hear me speak, but unfortunately. So I set out to study the relationship between violence and antiretroviral therapy, non-adherence among HIV-positive Ugandan adolescents. My aim was to investigate this violence among this population. My two specific objectives. One was to find out what the prevalence of violence among this population was, and number two was to study to investigate the association between the two, the violence and the antiretroviral non-adherence. Okay, so why these two things? Because both violence and HIV are global public health problems. Yeah, take HIV for one. Over 38 million people worldwide are suffering with HIV. 1.7 million of these people are below the age of 18, adolescents. And in the year 2019, 150,000 young people newly acquired the virus. Why, again, do we focus on it? Because sub-Saharan Africa is the worst hit region when it comes to HIV, with 80% of these young people living in that region. Yes? So why adolescents? Because adolescents actually have the worst HIV they have the most adverse HIV outcomes when compared to any other age group, in terms of them taking their medications or being adherent to their medication, in terms of progression to AIDS and other HIV-related illnesses, and unfortunately, even mortality. So it becomes imperative for us to focus on this age group. Yes? Okay, so for literature has shown that this age group also has the worst adherence when compared to any other age group. So again, it becomes imperative for us to focus on them. Also, living with HIV as an adolescent means that you have a higher likelihood of experiencing violence. And this is where the link comes in. Yes? So violence on its own is also a very big, next slide. It's also a very big burden worldwide, with more than 1 billion children in the year 2020. And children here, we mean people below the age of 18, having suffered some form of violence. Okay, so as you can see, in that same year, 1 in 3 students aged 11 to 15 had suffered some form of bullying. Still 1 to 3, about 13 to 15 had been in a physical fight. I don't know, can you click to view? Okay, it's okay. And 120 young people, women below the age of 20 and children, had faced some sort of forced sexual violence. Yes? Now, the link is that we already have seen that these young people have the worst adherence when compared to any other age group. And number two, they also have more mental health challenges when you compare them to those that do not have HIV. And these mental health challenges include psychological distress, major depressive disorder, and alcohol use. And these have been studied and shown to have a clear link to non-adherence. Now, because they have already the mental health challenges and the non-adherence, violence has also been shown to compound on both these things. And that's how we draw the link and why it's important to study the two together. Okay, so the innovation of this study was that, one, if you look at sub-Saharan Africa, Uganda inclusive, and much of Africa, this work hasn't been done. This problem has not been studied except in 2 places that we saw. Except in 2 places that we saw, that was South Africa and Zambia. And South Africa was only looking specifically at not adherence, but instead they're looking at virological failure. So it becomes imperative for us to focus on this work because it gives us a base or a foundation for us to create violence prevention interventions. In our methodology, this was a descriptive cross-sectional study. We used simple random sampling to come up with our population. We did it at Mildmay Hospital in Uganda, which is the center of excellence that provides holistic Ugandan holistic HIV care. And in our methodology, we used 3 tools. One was a social demographics tool, which was looking at things like age, sex, where they stay, how long it takes for them to get to health facility and things like that. We had a clinical data abstraction tool that was looking at viral load, duration on art regimen that they are on, and etc. And then we also use the International Society for Prevention of Child Abuse and Neglect screening tool instrument, or in short, the ICAST. The ICAST is a 77-item tool that is used to explore the experience of violence among these young people. ICAST-C specifically for children, which again looks for violence, different forms, including the ones that we're looking at, which was emotional, sexual, and physical violence, and overall violence being a positive answer to any of those 3. So it has good social psychometric properties in Uganda. Yes, so our analysis with DP-Info and Stata. We also described our social demographics. We used the descriptive statistics to describe them. And we used chi-squares and odds ratios to establish association. And we ran a bivariate analysis and logistic regression. Okay, so let me just tell you about our results. These are preliminary results. We set out with the Kish-Leslie formula. We came up with 300 participants. Of the 726 population that the hospital caters to. Now for the 202, this is what we're able to get so far we are continuing to collect data, but I just wanted to tell you a bit about the 202 that we have, the 2/3 that we have investigated. So their mean age was 16 years, standard deviation was 2 years, that the range was between 14 and 18. Most of them were below the age of, rather were above the age of 17. The male to female ratio was about 1:1. Most were in school, 83%. 75% of them were residing with relatives. And unfortunately, 14% of them were total orphans with no living relatives. The time that it took for most of them to travel to the facility was less than 60 minutes, and this is important because those who take longer in literature have been shown to have worse adherence to antiretroviral medication. The clinical characteristics, those who had been on antiretroviral therapy for more than 5 years were more than 90% or 95% of the population. And for those who have been on antiretroviral therapy for more than 5 years, in literature still, it has been shown that they have better adherence compared to those who have been on it for less than 5 years. Most of them, about 90%, had, no, previous slide, thank you. Yes, so about 89% of this population had viral suppression below 1,000 copies, and most of them were in HIV stage 1 previous. Okay, so this is what the violence that we found, the prevalence of violence. As you can see, overall violence was really, really high, 96%. Almost everyone in this population had faced some form of violence in the past 1 year. And you can see all of them were high, but sexual violence was also really high, 21.4% of this population. Next slide. Okay, and then the pie chart just shows you, it's a depiction of the adherence of this population. In blue, just point where the blue is. No? So that's in blue, it shows those who were, it shows the percentage of people who were non-adherent, and that was 30%. Next slide. Okay, so what were the implications of this? No, one back. Yes, we also ran a multivariate analysis, but as you know, this is incomplete data, and we shall rerun this when we are done. But it showed no significant association with between the social demographic variables and the antiretroviral therapy adherence. And however, sexual violence showed a significant association with non-adherence. With this population that had faced sexual violence being 3.3 times more likely to be non-adherent to antiretroviral medication. So I didn't tell you about the bivariate analysis. In the bivariate analysis, we came up with certain variables that had a p-value of less than 0.2 rather, and these included age, type of school attended, and sexual violence. And then there were others where we used the Hughes-Bradford criteria to include them because of the consistency with previous literature and biological gradient or dose response. So we included also time to travel to facility, duration on ART or antiretroviral medication, and emotional and physical violence, because they're the main things that we're actually looking for. Okay. So the implications of this were that there was a high non-adherence among individuals who had faced sexual violence, and this was a significant association, which indicated a heightened vulnerability among the subsection of the adolescents that we set out to investigate. So this calls for or provides a foundation for joint interventions for violence prevention as well as adherence. Okay. I have 1 more minute. Yes. So we had some challenges, but I'm just going to scream through these. Yes, there were certain delays at IRB and getting approval a little longer than we had foreseen. So that pushed us back, and well, the way we got through the delays were constant checking, polite nagging, and collaborating with people. So this pushed us into the school term where many children are in boarding school, and then that created another delay because of our sample. So anyway, we had to make phone calls in order to get these people. We had to target the events that these children have with their peers. And at the events, when they're done, sit down with one of them if they're on the list and all that, and talk to them after, of course, getting consent from their family and assent from them as well. Data abstraction delays because we had to use the mild-made team. We couldn't use our own people, so we had to train. Top of training, they only can do that work outside their own work times and all that. And all that increased our expenses, so it shot up our budgetary requirements, and this pushed me into my own pocket. But this was my civic responsibility to contribute to science and better my nation as a patriot. The way forward, just 98 more people that we need to collect. When we're done with that, we run a full analysis, and then we shall submit our manuscript, and I'll proudly update my credentials as having completed this prestigious fellowship. My next steps are, I want to publish my work. I really do. And this has propelled me. Thank you. Thank you. And this has propelled me to also publish work that I've been seated on. I mean, it has made it look all very, very possible. I hope to do that at least within the next 3 or so months. I know it takes longer, but one can dream. I'm also applying for a K award for 2 reasons. One, I want to continue to study violence prevention interventions in this population. And number 2, I want to start my PhD. So I'm thinking the K award will get some money, divert it into. Thank you very much for listening to me. I'll just acknowledge after the questions if there are any questions for me. Yes? Okay, fine. So I would like to acknowledge the program directors, Dr. Fred, Dean Mary, Vice Provost Mary, McKay, and Professor Noeli Nakasuja. For you, this may seem like a very simple thing. I mean, you've helped very many scientists and researchers progress in life, but for me, this is everything. There's no way you would have caught me dead 2 years ago standing in front of such a prestigious speaking what I think is sense and science. No, to my mentor, he's not here, unfortunately, but I'm very thankful to him, Dr. Kenna, for providing a study path in this very murky, difficult research world. He has been a very good person, a go-to guy, and he has helped me get through this with less tears. I'd also like to thank Professor Nakasuja, who's the program director, and also to apologize. I forced you into a mentorship role. Thank you for not chasing me away from your office and for providing all the wise counsel. I'm also very thankful to Fogati for the funding through this grant, for CHILD, Washington University, and Makerere University for making this possible for us and helping my country progress in terms of science. Thank you very much.
And thank you, Dr. Guma, for that wonderful presentation and for all the preparation that you have had to put into it to get it where it is now. And we look forward towards the final bits of whatever needs to be done. And we look forward to that publication. I know it is in the pipeline. It's just about to come out. And we'll celebrate when that comes. Our next presenter is going to be Dr. Letitia Chohangire. Dr. Chohangire is a research scientist at the Medical Research Council, Uganda Virus Institute, but she's also a psychiatrist working at the National Referral Hospital in Uganda, Butabika Hospital. Dr. Letitia, you have the floor.
Good morning, everyone. Yeah, thank you, Professor Nowen, for that introduction. Yeah, standing here under this podium facing this group is also not easy, but So my name is Dr. Letitia Chohanjirwe, as already mentioned. Yeah, a CHILD-GRF fellow, and I'm a psychiatrist. My mentor has been Professor Eugene Chinyanda and has not been able to make it, but we've been working all through together. And I set out to determine the effect of psychiatric disorders on clinical outcomes among adolescents with HIV in Uganda over a 1-year period. Globally, about 1.7 million adolescents are living with HIV, and majority of these are in sub-Saharan Africa, according to the report, UNICEF report. While ART or antiretroviral therapy has significantly improved the clinical outcomes, increased survival rates among adolescents with HIV, they continue to face numerous challenges, including considerable burden of psychiatric disorders, and up to 50%, as per previous studies done. So, and then we note that psychiatric disorders in individuals with HIV have been associated with negative outcomes. For instance, poor adherence to medication, risky sexual behaviors, faster HIV disease progression, poor linkage to care, and then impaired and social academic functioning. However, the relationship between these psychiatric disorders and negative outcomes can be bidirectional. And so, most of the research that has been done in this area has been mainly cross-sectional studies. So why we set out to do this study was because of the need for longitudinal studies to inform the direction of causality between the psychiatric disorders and the negative and outcomes. And so the aim is to determine the effect of psychiatric disorders on clinical outcomes using a longitudinal approach. So it is a longitudinal study design using a secondary data from a previously done study. It's called CHILD study. It looked at the mental health problems among children and adolescents with HIV. It was conducted in Uganda, in areas of Kampala and Masaka. There were 5 study sites. So the sample in this study for adolescents who are aged 10 to 17 years is 713, and was able to get access, was granted access to the data by the principal investigator. So we've been working through data cleaning and preparation, looking at trying to handle missing data through imputation or exclusion, checking outliers and anomalies. We've also gone ahead to do selection of variables of interest. We have socio-demographic variables, for example, age, sex, residence, HIV status at birth, education level, and also clinical outcome variables, looking at adherence to HIV treatment, disease progression, that is considering the new WHO clinical stage 3 or 4, looking at number of, having hospital admissions in the previous 1 month, number of visits to the health facility, and then we are also gone ahead to use descriptive statistics to summarize the baseline characteristics. And then we plan to use generalized estimating, equations for binary outcomes to determine the effect of these different psychiatric disorders on these outcomes. We are also going to use the Poisson regression models for the count variables. So these are just preliminary results of which we've worked through. We only have, so far we have baseline characteristics of participants. So we've noted that median age is 13 years, approximately same number or same percentage was comparing 51.5 are females compared to 48.4% who are males. We have a missing data in this. And then also approximately the same number living in rural area and urban area. And also have missing data on this of 12.5%. HIV status at birth, majority were born positive, that is 93.1%. And then majority also of these participants in primary school, that is 76.9%. And then followed by those who are in secondary. So we are continuing with data analysis. The next steps is to follow up with the IRB approval. I've already submitted approval to UVRI, Research Ethics Committee. They've responded, they've given comments, which I've responded to. I'm just waiting for the data and then complete the data analysis. And then I hope that by June, I'll be able to have done the manuscript, drafted the manuscript, and also submitted it for publication. I would like to acknowledge, my mentor, Professor Nyanda, the PIs, program PIs, that is Professor Noelin, Professor Fred Sewamara, Professor Mermaki, CHILD-GRF fellows, Makerere University, ICHAD Brown School, Washington University, St. Louis, Forget International NIH, Forget International Center, Medical Research Council, and then Butabika National Referral Hospital. And I'm really so grateful for this program that I've been able to come to America for the first time. What can I say? So, yeah, thank you all for listening.
Thank you, Dr. Letitia, for that wonderful presentation. Very beautiful slides. Dr. Letitia was the last to receive her visa on Friday, and we're traveling on Saturday, so you can imagine how much tension we had in preparing the slides and also waiting for the opportunity that the CHILD-GRF has done for our fellows is to not only focus on different topics within children and mental health, but also the research skills. So slowly, we are turning her into a statistician because she's dealing with a data set of data she never participated in collecting, but she's going to tell us, whatever it is that is coming out of the causality of mental health challenges for children afflicted with HIV. We'll reserve the questions to later. We'll move on to the next presenter for this morning. The last presenter was not able to make it. I still don't see her in the room, but hopefully we'll have an opportunity to interact with Dr. Damali Nalwanga when she later comes in. to tell us about cognitive challenges and how the community perceives this for children that have HIV. But the next presenter for now is going to be Dr. Emmanuel Mpamizo. Dr. Emmanuel Mpamizo is a psychiatrist and a lecturer at Gulu University in Uganda. Dr. Mpamizo, you're welcome.
Yes, thank you all. I'm Mpamizo Emmanuel. I'm glad to be here. I'm going to tell you about the interesting work I've been doing under this fellowship. The title of my presentation is Mental Health Services for Children and Adolescents with HIV in Uganda. So in simple words, we want to know if a child has HIV in Uganda and he has a mental health problem, what can be done or what is actually being done for that child. My mentor was Dr. Catherine Abo. So we know that mental health services have been highlighted as a problem area. Even in places like America, they are not readily accessible, but even when they're accessible, professionals are not there. The situation is worse in sub-Saharan Africa, where there is a problem with infrastructure, there's a problem with the human resource and other problems, but we know that something is happening on the ground. So the goal of our study was to identify what exactly is happening on the ground, and we had the following research objectives. So the first thing was to explore the current state of mental health services for children and adolescents with HIV. In other words, what is happening. And then the second objective was to understand the barriers and the facilitators to the provision of mental health services. So what comes along the way there? What helps people be able to administer mental health services, or what interferes with the provision of these mental health services? And then the third barrier was to explore potential solutions. So what can we do to try and improve the provision of mental health services to this population? We employed a qualitative study approach, and we recruited health workers who are actively involved in the provision of mental health services to children and adolescents with HIV in Uganda. Specifically, we went to health workers working in the Gulu sub-health district. This is a part in northern Uganda, which has been facing some of the atrocities that were mentioned earlier. So we collected data using focus group discussions, but we also carried out some key informant interviews. This study was registered to the National Council of Sciences, and also we obtained ethical approval. And we got written informed consent from every participant before we started collecting the data. Okay, so these are some of the people we were able to recruit. We recruited a total of 45 health workers. Many of them were nursing officers. More than half were female. Interestingly to note, we're able to get some Ministry of Health official, a district health officer, and then all these other people who have a role in the provision of mental health services to children and adolescents with HIV. So we have begun thematic analysis, thematic qualitative analysis, and these are some of the things that are starting to emerge. So at the top of the slides, you will see mental health services offered. So we are trying to inquire and get the codes that are starting to occur. So what exactly is happening on the ground? And these are some of the things that we are being told. So people, health workers talk to patients. Some of them offer counseling. And then also something which seems to be working very well was the issue of peer support. So people who are either older, they are no longer adolescents, or who themselves have HIV and have gone a step in the journey than other people behind who are doing a great job. Then also the issue of home visits, where health workers go to the homes of these people with HIV, and then also other community programs. Facilitators, or things that are making the provision of mental health services easy. We came across people who are telling us they have been trained in mental health problem, they have been trained in mental health, and then also support from other health workers. So people who are not necessarily health workers dealing with HIV. So like the way you are mentioning lab technologists, we found that even lab technologists sometimes, because of the burden, come out and interact with patients and are expected to deliver certain services like all the other health workers. But they were doing it, and they're doing it without much of a problem. Only that they were complaining, as you see in the barriers, lack of knowledge. Some of them have not been trained in administering mental health interventions or even screening for mental health problems in children and adolescents with HIV. An interesting one we came across was boring health messages, maybe, and they were specifically mentioning the Ministry of Health, that Ministry of Health has boring and monotonous mental health messaging. Maybe something can be done to change that. And then also another one was that the focus is so much on HIV medication and viral load. Even when, so, and they mentioned that this is at all levels. So the first thing is that the health workers themselves, once the child comes in, what they want to know is, are you taking your medication? Whether you're sad or what, that's, not too important. It's important, but not too important, because even when you capture the information, you have nowhere to put it. What they want, because you have to report to the higher levels, and the higher levels are interested in, are people taking their HIV medication? How many numbers have you recruited this year? There's really not too much focus on mental health. Although there is a change now, the interest is starting to come, but in the past, the focus has been so much on HIV medication and viral load. Okay, so conclusion, what are we concluding? I should mention that we are still analyzing the data to come up with a final manuscript. So the conclusion is that there is a range of mental health services that are currently being offered in Uganda for children and adolescents with HIV. They may not necessarily be structured, but something is happening on the ground. The other thing is that external support is also doing a great job. So when we talk about external support, are things still which you have mentioned here in this forum. So things like the churches, things like researchers like yourself, people from abroad, Washington, coming to Uganda and doing something on the ground has been recognized and is improving mental health services. However, the big problem is that there is limited knowledge in the provision of mental health services. So people really don't understand mental health problems. And still this is still it's a multi-level kind of thing. So, and on the ground, the people who have mental health problems themselves, the children and adolescents, don't know that they're having mental health problems. Their parents don't know that they're having mental health problems. The health workers, while they have some knowledge, still don't know how to properly address it. So the issue of knowledge is a big one. One of the solutions which we got, which was suggested by the health workers themselves who we interviewed, was that there needs to be some kind of literacy program to improve the knowledge still across all these levels. So what is the implication for practice? So I've done the study, thank me very much. I've done a good job, but what are we going to do with this information? One of the things which came out are still things which I've mentioned in this very this forum is that health, economics, and poverty are intertwined. We would find, for example, a family has maybe a family of 5, around 3 people have HIV, and they are all required to attend the clinic. So what happens on the ground is that they send one person, usually the adult. So the child themselves may not come. Other problems is that, like, in the rain season is when planting takes place. So people are preparing their gardens, agriculture. Majority of the production is involved in agriculture. So in the rain season, the attendance drops because, people are focusing on agriculture for a living, HIV and what is very good, but I have to, provide for myself. The other thing which also needs to be, which we can study on more, is the role of home visits in the care of people with HIV. We found that home visits are being done, but they are not really delivered in a structured way. There are no guidelines of how it should be done, what time you should go to the home, who should go, and what exactly should be done there. They are being done, and it seems they're effective. So maybe something can be done to try and study the issue of home visits and maybe optimize them for this particular population. The other thing also which I think came out was the issue of disclosure. So some children do not know that they have HIV. Others know that they have HIV. The Ministry of Health has released very clear guidelines on how the HIV status of a child should be delivered to them. Unfortunately, for some reason, these guidelines are not being followed. It would be, and because of that, mental health problems occur. So a child grows up, he is starting to understand things. He's around 10 years, 12 years. So he understands that he's taking a pill every day, but his sister is not taking a pill. So it affects him in a certain way. So in other words, HIV disclosure guidelines are there, but for some reason they're not being followed. Can we study this issue and see if we can and do something else, do something about it? And then also the role of improving mental health literacy. What can we do to improve mental health literacy? Still, as I mentioned, across all levels. And then finally, there is issue of sexual or romantic relationships, because still we discover that people drop out of care when they begin to engage in sex, or when they begin to get romantically involved. They are not able to attend the clinic every day because they're with this person at night. They can't take medication, the issue of sex and all that. So this is something important also, which we can explore and see if we can design some kind of intervention around that. Okay, so finally, what have I learned from this study? So being a junior researcher is like being a bricklayer. So that would be a research trainee, the gentleman at the bottom there throwing the brick. And then what you're throwing is your research project or your research idea or your research paper. And then the person at the top is the supervisor or the reviewer. Sometimes you throw what you think is a nice brick, and then the researcher throws it back at you saying it's not perfect, look at it again and things like that. Yet you've spent, energy and and time trying to do it. So you sometimes still you're so enthusiastic, you're too energetic, you want to throw 2 bricks at the same time, or maybe you're throwing bricks at a very, very high rate and the person receiving them is telling you to slow down, just like the way people are telling us here that you send something for review and then it's sent back maybe a month later. Yet for you thought it was going to be reviewed in 3 days. So, but still I've learned that, with time and determination and effort, you'll be able to create a good brick. Thank you. Yes, I would like to acknowledge the following people: Professor Nakasuja, Dr. Bo, Dr. Fred Sewamala, and the whole ICHA team, Dean Mary, Gulu University, as well as my fellows. The support you've offered me has been very intense. Just today morning, I got some feedback from my professor who told me, Dr. Nakasuja, who told me, when giving the presentation, you have a problem. Sometimes you get carried away by stories. Make sure you don't give too many stories. So thank you very much, Professor Nakasuja, and everyone.
So to all our presenters, I welcome you to the podium for the Q&A, because the audience would like to understand your researches better. But as they do walk up, each of you fellows realizes that whatever it is you've started has so many ramifications, and the whole purpose for this fellowship was for us to grow you into researchers in your specific fields. And from what you've so far presented, I can see we are going to have a lot of work for you for so many years. You just have to have the tenacity to carry through with the work that needs to be done. So we will welcome questions, comments. Okay. So as you come up with questions, there are 2 in the chat. So Dr. Kennedy, Mr. Kennedy Ntambi is asking Dr. Guma, how is going to handle the issue of budget limitations to the extent of going into his pockets, as he reports. Did he think of a supplementary budget to the program directors or funders? Won't this limit his program activities in one way or another? Dr. Guma?
Thank you very much. Yes, I thought about requesting for supplementary funding, and it would have been a preferred course of action. But I was looking at the timelines that I had, and probably CHILD-GRF would have given me the funding. However, the time that I had to complete my work have some results, present it. And even for me, the waiting and all that, I needed to see where this was heading to. So I went into my pocket. Again, I thought of it as my civic responsibility, and I would do it again. However, it may not be sustainable. I think I just need to learn how to plan better in order not to have delays. Think about things like the incidentals, the financial incidentals that I may not have seen, and plan for them as well. Yes, thank you very much.
Thank you, Dr. Guma. The next question is from Andrea Bulungu. He's sending greetings from Kampala, and he congratulates all of you for making your presentations. This question is for anyone who wishes to address it. Adolescents are widely recognized as being particularly hard to reach. What have you learned about the community-based platforms in Uganda, other than school, that are effective for reaching adolescents in Uganda with health-related messages and services? So while it said anyone, I think I will start with Dr. Mpamiso.
Yes, thank you very much. Thank you very much. Adolescents are a very picky group of people, and I was able to see it in my research. But the Ministry of Health has something it has innovated, which is called the youth corners. The first thing is that there are separate youth days where the agreement is that adults should not attend children and adolescents clinics. So the children and adults should be alone in their clinics, because this adult is the same one who is serving you at the market, is the same one who is going to drive you in the taxi to school or something like that. So sometimes these children don't want to interact with the adults, the children and adolescents. So the separate youth days have helped, and then also the what are called youth corners. Now the youth corners have things that appeal to the youth. So you find nice paintings, you find music, you find television with the hip hop stars and things like that. And it also appeals to the youth. They attend more the clinic when these things are there. And the hours are a little more flexible than those for the other adults. I think that is what I've seen. You have to design something specific for them and know that they are not just a small adult.
Okay, so school is one of them. The health center is another. Does any of the other presenters have any other platforms on where we can approach children and adolescents?
Yes, I think because for me, what I saw with the study that I was doing is that the peer supporters are very, very, very key, very important. When we set out in the first week, I think we interviewed about 10 participants. This wasn't because we hadn't gone through the right channels, but because we hadn't gone through the right people to help us find these adolescents. They relate with them and they listen to them. And it was easier for us to come up with the what the random number generator had given us to come up with those participants after going through the peer supporters. And even when we attended one of the events, it was really, vibrant the way they were associating with these adolescents. So I'm thinking if there were to be a program, perhaps it would be one that would also inculcate the peer supporters in giving out that information, seeing as they're relatable, they are young, they understand some of the culture, things that are culturally different between the generations that some of us might not get, but these adolescents do. So perhaps if there were an intervention, maybe it would be one that would include, even if it were social media or whatever, one that would include the peer counselors. Thank you.
Right. So that is for the HIV positive child, right? Yeah, and yet you mentioned to us that that the rate of HIV in these children is still high, or not to levels that you would desire. How about any other platforms that we can use to reach children and adolescents so that we curb HIV and the challenges that come with it? Anyone? Oh, sure. It's a discussion. Yes, and we'll come to you.
Thank you. I think from the work that I have been involved in, particularly now at a global level, working to get spaces where we can reach out to children and young people. There's using sports, football, we call it play football or any game that you can get them interested, and many of them, we have been able to reach a lot of them through sports and games. The other one is through music, dance, and drama. A lot of them get engaged in that. And the statistics now show that a lot of children and young people spend a lot of time online. And so there are those spaces online that are created specifically to engage with them on that. On our part, we've done what we call the Twitter Spaces, where it's basically just for young people. We've not done it for Uganda, we've not done it for Africa, but I know that we are planning on one for Colombia prior to a conference that is going to be taking place in Colombia. So that is one that I thought I should respond to. Can I just make my comment? And
Sure.
I had a comment for the name has gone.
Guma.
Dr. Guma and you. For Dr. Guma, one of it's interesting to see that you focusing on violence prevention. That's really my specialty. There is a global conference where your information can be used. There's a global interministerial conference that is going to be happening in Bogota, Colombia. I talked about in November 2020 this year. And Uganda is amongst the countries that is preparing a position paper on what it is, the key issues that we need to be focusing on, and the linkage between violence and HIV/AIDS would be a good message, a key message that would come in. WHO is leading in Uganda, and I am supporting WHO in working on that paper. So if you talk to me nicely, I don't mean the nice Uganda way, but if you talk to because if you talk to me, we can have a line in that document that will be presented in Bogota. Globally, there are about 38 countries that have committed to end violence against children, that are doing pathfinding work. But out of that, only 30 that are going to be featured, and Uganda is one of the countries that will be featured. So we're doing a documentary, we're doing a paper that will be presented by the ministers. We are hoping, and again, if I talk to somebody nicely, we're hoping that the Minister of Health will be there. I'm praying. If I talk to George nicely, the minister will be there. So we are trying to get that. So that could be a key message. And then for Eugene, Emmanuel, it's also about, and thanks for your paper, very interesting. One thing that I picked is about the correlation between health economics and poverty. You also talked about the issue of disclosure. I don't know whether you, in your study, you came across, I know a couple of years, I wrote a briefing paper on proxy testing, where parents use their children as proxy. I don't know whether you came across that they don't want for them to know their status, they present the children, that you go and test. Proxy testing has been used in the past. And then the other one is also like disclosure. Many a time the parents are not telling children why they're taking the antiretrovirals, so they just tell them to take, and then no, this medicine is good for you and it's good for you. So nobody else, like nobody's implementing the disclosure guidelines as it were by the Ministry of Health. The other point is also about the communication, you mentioned something about the ministry being interested in numbers, which is true, because I immediately asked and said, but is it true that it's numbers? But it's true a lot, even at a global level. WHO will ask about numbers. How many have you reached? Viral loads, how many have you been able to, how many have suppressed? That is what they're interested in. But also having this out there, because that you now have the evidence that there is a link between that and mental health. If you could just make this information available to be known. So that's what research is about. Do it so that they know that it's out there. Even if they don't focus on it, you are the person who should highlight it and bring it out. Thank you.
Thank you. So, Dr. Mpango, then Professor Biachika. Behind you first.
Oh, thank you very much, the presenters. My first question goes to Dr. Guma about the instrumentation of the tool, or the validation. Did you do the validation of that instrument that was
not
used
the
to that
question.
population?
The tool was.
That's not the question.
Okay. My other questions go to Dr. Mpamizo. There have been so many interventions in the North. Did you look at interventions in schools and how effective they've been? Community models that have been reaching out to the children, adolescents with HIV, how effective have they been? What's the way forward if you're looking at addressing the gaps? This model, Professor Fred's model, is quite effective. The relation between economics and poverty and HIV. So is it feasible to use this same model within that setting to see how it works? Thank you.
Right. Thank you. We'll just note your questions. Let's collect from the room. So Professor Biachiko.
Thank you for very interesting presentations. To Dr. Guma, it's interesting, but very sad to note the association between sexual violence and non-adherence to ART. And she commented on what I wanted to say, but I'll still say it. I'm just wondering if these participants in your study actually understand why they have to take ART, because your findings showed that those who experienced sexual violence were 3.3 times more likely to be non-adherent to ART. We would expect the reverse. Would expect that if one is experiencing sexual violence, they should be more adherent to their ART. But your results are showing the reverse. I'm wondering if you explored their knowledge and understanding of why they are taking ART. And is it Letitia? Yes, Letitia. Your findings will be very interesting regarding clinical outcomes and mental health, longitudinal study. Many times we face patients with psychiatric illness who have infectious diseases, HIV being one of them, TB the other. And we are faced with a dilemma on how to treat them, especially if they don't have social support, because it's very difficult for them to take the medicines, to be adherent, especially to treatment of infectious diseases where you really need good adherence. So what do you think is the solution for these kinds of patients? But also we know that the same patients who may have mental health issues, who don't take their medications and go out in the communities, many times experience sexual violence. They're raped. And this is another cycle for continuity of transmission of disease. What do you think is the solution?
Okay, thank you very much, Professor Biachika. We'll have one last question at the back, and then we'll let you respond.
Thank you so much, Dr. Norin, and thank you so much, the presenters. My question is about, apart from the publications, which other plans do you have to present the findings to the participants that engaged in this research? Thank you.
The light is against me. I can't see her face. I'm sorry.
My apologies. My name is Rashida Namirembe. I'm a first year, second semester social work PhD student. Thank you.
Thank you,
I have more question online.
Right. Okay, so we'll now listen to your responses.
Should I go first?
Yes, in this order.
Thank you very much. Let me attempt to answer these questions. About validation, this tool has been used in multiple countries, and it was actually pre-validated for Uganda. It had very good social psychometric properties for our region, and Additionally, because when this tool has different forms of violence that it looks at, including including emotional, physical, sexual violence, as well as witnessing and neglect, as a form of violence. However, we only took out the components that were important to the entire tool was answered, but for the purpose of our research, we only selected the questions that were focused on emotional, sexual, and physical violence. So we're also going to run a Chromebook Alpha to see if it was okay to do that with our tool. But yes, it has good psychometric properties for Uganda. Yes, Professor asked, do the participants understand that they need? I think this would have been very important information for us to get. However, it was a bit outside our goal or what we set out to do. And I think, thank you, because I think this is one of the things that we could investigate going forward. Because now we are looking at the association, yes, between violence and non-adherence, but there are other things that could be confounding that relationship. So thank you. We shall consider that going forward. But also the extent of our inclusion was if the person knows their HIV status. That was the extent that we went to when we were considering if they knew that they should be taking the medication or not. No, we just looked at, do they know their status? Have they been in care for longer than a year? Do they speak English or Luganda? And yeah, basically. But we shall include that. Thank you very much. Plan?
Yeah, please complete the ones.
Yes, now, luckily for me, in my study, I collaborated with someone in the top leadership at Mildmay, and this means that it will be easy for me to present my findings, both to the Mildmay leadership, the Mildmay team, the participants themselves. We shall find a way of presenting this work in a way that will not harm them psychologically, in a way that will continue to protect them, and also that will help them understand that they need to remain adherent despite whatever circumstances are happening in their lives. Thank you.
Thank you, Dr. Guma, for those responses. Dr. Mpamizo.
Yes, I received a question. So someone is asking, a lot of interventions have been carried out in the community. What did you find about that? That is true. A lot of interventions have been carried out in northern Uganda. So northern Uganda, just a background, was the site for this long civil war between the government of Uganda and that infamous rebel, Joseph Kony. But the war ended about 15 years ago. At the time when it had just ended, there was a lot of interest in the region. There were a lot of people doing a lot of work there. But now the complaints, some of them we captured them, was that they have gone away. All those funders and researchers have gone away. Some work was done, but now the interest has gone away. But we are going to, I think, reassure them that we are not gone away. We are still there. We can still do something with them, which ties into the second question. Someone mentioned at the end, apart from publication, how are you going to use these results to benefit the community? We are going to go back. We shall go back and communicate what we have found to them. And we shall try to do it at all levels, at the high levels, and then even down to the children and adolescents with the mental health problems. Thank you.
Right, and as we discussed in the morning, sustainable programs, you're carrying on this work in the community for people to appreciate mental health services in the community. Lastly, we'll have Dr. Letitia. Any specific question that you would like to respond to?
Specific question from Professor Byachika mentioned about psychiatric illnesses in individuals. Okay, individuals having both psychiatric illnesses and infectious diseases, for example, HIV. What is a solution? So I think we should think about integration efforts. Minister of Health already has put up, I think there are some guidelines already in place to integrate regarding integration management of people who have having comorbidities, that is having psychiatric disorder and then another infectious disorder, instead of having different clinics have one clinic managing both. I think that can be so helpful. Also training of health workers so that everyone is knowledgeable. People have knowledge on how to handle mental health issues, and also even the people who are managing mental health issues should have some level of knowledge on how to be able to manage these other also infectious diseases. So the integrated efforts, I think, would be helpful. Then I don't know if I've.
Right. Thank you, Dr. Letitia. One last one for you online. You had some items that were missing data. So Mwanguzi Moses would like to know how you're going to deal with that as you analyze the data set.
Regarding the missing data, we're trying to look at on how we can have some computations to handle that missing data. We work through with the statistician to be able to handle that missing data.
Great. So we'll clap for our presenters. Thank you so much for the work that you're doing and the response that you've given to your presentations. And we look forward to the future of whatever it is that is going to come out of what you continue to do. Thank you very much. But before you go away, the bishop has finally arrived. Bishop Jumba, you're very welcome. And we know you had challenges getting here, but we are excited that you finally made it. Dr. Ebo Mwebembezi is also here. Thank you so much for finally making it here. My role is now done. The MC, please take over.
Thank you, Dr. Nolan, for moderating 2 back-to-back sessions for us. That was masterfully done. Of course, you're a professor, so we expect nothing less from you. Thank you very much. And that was wonderful, wonderful presentation from our CHILD-GRF fellows. As you can see, they've done a great job in the last 3 years. They've spoken before the minister. I think the next time they speak, maybe they'll speak before the president and they will not be afraid, right? So now comes the one of the most important parts of our session today. We'll break for lunch. We'll break for lunch. And for those of you who are having lunch, lunch is just outside. So you can go grab your lunch and come back in and have lunch here. We will reconvene here at exactly 1:30 p.m. And we'll get you back here. That's the whole plan. We will have our lunch here so that we don't go anywhere. For those of you who are on Zoom, please go have lunch somewhere or dinner where you are. Thank you very much. Please, let's keep time. Enjoy your lunch. Thank you.